Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Lake Town Synergy to commemorate Charles Best, and I congratulate rather Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic fees over the coming times. Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic fees over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate rather Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really, really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Laketown Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that ENDIAB Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Laketown Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you, happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Santosh, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate rather Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that ENDIAB Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Laketown Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate rather Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really, really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Laketown Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate rather Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of Hope you all enjoy the academic feast over the coming times.
Hello. Mute করেছে। কিসে? কোনো কিছু নেই তো।
কিরে কটায় শুরু?
আমি তো রয়েছি, আমরা সবাই আছি ইনফ্যাক্ট।
ঠিক আছে, ওকে, ভেরি গুড। স্যার গুড ইভিনিং। গুড ইভিনিং। অপশনটা কোথায় গেল? বিআই এই আমাকে ইয়েটা বলো, টিম 1 2 3 4 করে বলো, 6টা টিম,
5টা টিম।
5টা, আচ্ছা ওকে। টিম 1 মিতা, টিম 1 কে? বিআই?
আরে এইটা ফুল স্ক্রিন।
টিম 1 বিআই, টিম 2 কে?
Sir, team 2 GLP, Novo GLP.
নোভো জিএলপি।
Yes, sir.
আর টিম 3
কি হচ্ছে শালা?
মিতা নোট করছো তো? বিআই, নোভো জিএলপি,
কি হলো রে?
তারপরে 3 নম্বর টিম
স্যার সানোফি ইনসুলিন।
সানোফি কি ওরাল?
ইনসুলিন।
সানোফি ইনসুলিন, আচ্ছা। আর টিম 4
স্যার
নোভো ইনসুলিন। বাবা সাংঘাতিক কাণ্ড, নোভো 2টো টিম উঠে গেছে। আর টিম 5
San Arian.
আরে বাবা গ্রেট। এরিয়ান কোথায়? সান কি ইয়ে গেলে সবাই একসঙ্গে তো নাকি না শুধু এরিয়ান?
শুধু এরিয়ান।
বাবা গ্রেট, ভেরি গুড। সো কনগ্রাচুলেশন এভরিবডি। তাহলে সৌম্য কি কুইজ দিয়ে শুরু হবে না ইনোগ্রেশন হবে, কি হবে?
হ্যাঁ সঙ্গমিত্রা
স্যার রেডি।
রেডি।
আপনি অ্যানাউন্স করলেন, ভিডিও চালাতে শুরু করব পরপর।
So we are on the second day of the Charles Best Memorial Day related ENDIAB Summit 2022, and we would start the day. In the morning we had gone to Dr. Devashish Majhi, who is a senior most endocrinologist in town, for his opinion. Sanghamitra, could we have the bite?
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11th to 13th February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Thank you so very much, Devashishda, for your opinion. And after that, we had taken a trip to SSKM Hospital, and there we have met with Dr. Subhankar Chowdhury. Let's hear him before we go for the inauguration ceremony.
It gives me great pleasure to be part of the 9th ENDIAB Summit, which celebrates, observes the birthday of another great person related to insulin discovery, related to diabetes management overall, namely Charles Best. And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success. Thank you.
On we proceed for our inauguration ceremony, which is customarily lamp lighting. And after the lamp lighting, we would start the quiz proceedings.
Shubham Kurutvam Kalyanam Arogyam Dhanasampadah Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute.
I bow to the light of the lamp, which brings auspiciousness, health, and prosperity. Salutations to the light of the lamp that destroy feeling of enmity and ignorance from the environment and the mind.
As we enter into the lamp lighting ceremony virtually, due to prevailing scenario of the pandemic, we see Professor Subhankar Chowdhury, Professor Anirban Majumdar lighting the ceremonial lamp, followed by Professor Debmallo Sannal, Dr. Ajoy Bishwas, and Dr. Soumyabrata Chaudhuri. Their pledge perhaps is to remove the darkness and light the management of diabetes and endocrine disorders with the glow of knowledge dissemination. Wish you all a great academic feast ahead.
So there goes the lamp lighting ceremony. And as you all know, this time the pharma industry quiz has been renamed in the memory of Mr. Santosh Rastogi. And after a brief remembrance of him, it will be over to Professor Anirban Majumdar for carrying on the proceedings. Shangomitra, could we have the Mr. Ras?
From the very first day of our journey of Charles Best Memorial Day, from Yuva Bharati Nilanjan, we had received unrelenting support in the form of Santosh Rastogi. Not only us, everybody in the field of diabetes perhaps have had a hint of his presence and support for everyone, irrespective of name, stature, anyone in need. Our dear Santoshda was there. And unfortunately, we have lost him in our war against COVID, a loss that can never be repaired by any newcomer, perhaps. From this year onwards, the pharma industry quiz, which was a big part of this event, a USP, so to say, of this event, is being named after Santoshda as Santosh Rastogi Memorial Quiz. We also fondly remember the likes of Nirupam, Chinmoy, Shobhan, and many anonymous colleagues from the pharma industry who have lost their lives in our fight against COVID. May their souls rest in peace.
So,
over to Professor Anirban Majumdar for the Santosh Rastogi Memorial Quiz.
thank you, Shomo. And we fondly remember him. So, after remembering him, let me start the quiz. So, I think we have 5 teams here. Team 1 BI, Team 2 Novo GLP, Team 3 Sanofi Insulin, Team 4 Novo Insulin, Team 5 Sanadian. So very good. I think I'll first would like to share my slide. Is the slide visible?
Make it full screen, please.
Yeah. So the quiz has been divided into 6 rounds. So I think if the time permits, we'll go up to 6 rounds. But otherwise, if we have short of time, then we can actually cut short the quiz rounds. Now 10 marks for each correct answer and 5 marks for each partial answer. So it is the quiz master decision to give 10 marks or 5 marks. Now 20 seconds time to respond. Shangumitra, 20 seconds. Can we have the timer? So the first question to the BI. Round 1. So a newly detected type 2 diabetic may have all the following signs or symptoms except blood effusion, ketosis in the urine, glucose in the urine, poor wound healing, protein in the urine. Shangumitra, the timer.
Sir, our answer is option E, protein in the urine.
So this is the wrong answer. Ketone in the urine is the right answer because type 2 diabetes usually don't have diabetic ketoacidosis, but they may come with nephrotic range of proteinuria or proteinuria. So second question to Novo GLP. A patient has classical symptom of diabetes like polyuria, polydipsia. Which value of random blood glucose will confirm the diagnosis of diabetes? You have 4 options, A, B, C, D. Novo GLP.
Sir, our answer is more than 200.
More than 200. Answer C?
Yes, sir.
C. Okay, C is the right answer. So I think 10 marks to Novo GLP team 2. Team 3, Sanofi. The target blood glucose level in patients in intensive care unit. Sanofi. A, B, C, D. You have 4 answers, 4 choices.
So C, it's 140 to 180 mg per dl.
C, yes.
Sir.
So, okay, this is the right answer. So, Mita, so C is the right answer, 10 marks. Team 5, Sanarian. Pre-diabetes or increased risk of diabetes when glycosylated hemoglobin. A, B, C, D. You have 4 choices.
Sir, our answer is answer A, 4% and 5.6%.
Sanadian. No, it is. No, Novo insulin jabe na. Oh, sorry. I think question 4 will be for Novo insulin. Question 4 for Novo insulin.
Sir, my answer is B, 5.7 to 6.4.
Yeah, 5.7 to 6.4 is the right answer. Very good. So next, question 5 to Sanarian. Yeah, this is your question. What is the main diagnostic criteria of latent autoimmune diabetes in adult? So you have A, B, C, D, E. GAD antibody positive, fasting plasma glucose more than 250, HbA1c between 6.5 to 7.5, exocrine pancreatic disorder, endocrine pancreatic disorder.
Sir, our answer is A, GAD antibody positive.
Okay, very good. Right answer. So with this, I end the first round. Mita, score?
Hello.
Hello.
Hello. Unmute and talk, please. Hello.
Hello.
Yes. Score, please.
Yeah, can you hear me?
Yeah.
Yes, BI Guardians is yet to score. All others are on 10.
Okay, so very good.
Nivanda, I will take 1 minute time after your next round for a surprise.
Okay. So we have many more questions. Now coming to round 2. It is on management. So first question to BI. Which oral diabetic medication has the following side effect? Diarrhea, stomach upset, lactic acidosis.
D, metformin.
D, metformin. Okay, very good. Right answer. Next, Novo GLP. What drug increases blood sugar by stimulating glycogenolysis in the liver? Glimepiride, glucagon, sitagliptin, metformin, empagliflozin.
Sir, our answer is option B, glucagon.
Glucagon.
Answer is option B, glucagon. Very good. Right answer. Team 3, Sanofi. What oral antidiabetic stimulate beta cells to secrete more insulin and decrease receptor sites in the tissue? Ripaglinide, acarbose, pioglitazone, metformin, empagliflozin. Sanofi insulin.
Sir, it is C, pioglitazone. Sir, A, ripaglinide. A, ripaglinide.
A, which one?
Sir, A, ripaglinide.
Okay. So, ripaglinide is the right answer. Next question, Novo insulin. 4. What is the side effect of meglitinides? Weight gain, euglycemic ketoacidosis, diarrhea, vitamin B12 deficiency, edema, bladder cancer. Novo insulin. No answer?
Weight gain.
Huh?
A, option A.
Purota bolo.
Option A, weight gain.
Weight gain. Okay, weight gain is the right answer. Then 5. Sanadian. If you take insulin, drinking alcohol can cause low blood sugar, can cause high blood sugar immediately, can cause high blood sugar after 48 hours, has no effect on blood sugar.
Sir, answer is answer C, can cause high blood sugar after 48 hours.
No, wrong answer. Can cause low blood sugar. So now we have
pass option nahi kono?
Huh?
Bonus option nahi?
Nah, bonus option nahi. So we have second round completed. So Mita, score?
BI Guardians is on 10. Novo GLP on 20, Sanofi insulin on 20, Novo insulin on 20, and Sun Arian on 10.
Okay. So coming to the
round 3.
Round 3. Management again.
Only one the minute nebo.
Oh, yes. Sorry.
Could we have a surprise here? Could we have Mr. Rajashree Desharkar unmute? We would like to have just a minute's time on Mr. Santosh Rastogi, one of his very close colleagues.
Meeting আছে একটা
Thank you very much, sir, and
পরে ফোন করছি আপনাকে মিটিং
Dr. Nimran Mujumdar, Dr. Devmalo Sanyal, as well as Dr. Ajay to dedicate this pharma quiz in memory of Santosh, who himself has been a symbol of sincerity and dedication when it comes to his profession. I must say that, and I must humbly admit that I was lucky to have a colleague like him for a great span of my career, and he has been a great success story himself and has helped me to win great laurels for Novo Nordisk in our professions, winning back market shares and so many good things. He will always remain in my heart, and I was very emotional to see the wonderful AV that you have prepared for Santosh, as well as dedicating it also to Nirmam, Chinma and Shubham. And this pharma quiz has been unique for this conference, and I was recalling that every time, every year, one day ahead, he used to come and tell me, boss,
we have to give the best name in his pharma quiz. And that time he used to forget which team he was belonging. He was saying, please let us select the best names who are good in science, irrespective of whichever team they are belonging, and they should represent in Novo Nordisk. So that was he, in short. And I thank you all once again for calling me, inviting me for talking about Santosh. He will always remain in our heart. And thank you very much once again.
Thank you, Rajarshi. Thank you so much for being there. Anirbandha, over to you.
Thank you. So coming to the round 3, again starting with BI. So fast-acting insulin start to work in about a minute, 15 minutes. I think the question is out, so I'll go start from the question 2, because we have got 5 minutes time to check the Google. Is it not? No more?
That is always there in the A round. That is always there in that Google form round. They have 30 minutes time to check 20 answers.
Okay, so let me start with question 2, BI. So where shouldn't you yourself give yourself an insulin shot? So BI, where shouldn't you give yourself an insulin shot? All the questions are on insulin. Back of your arm, lower buttock, outer thigh, belly, upper buttock. You shouldn't give yourself an insulin shot.
Lower buttock.
Lower buttock, yeah. So that's a right answer. Very good. So next is Novo GLP. All question on insulin. Now, which type of insulin has onset 30 minutes, peak 2 hours, duration 4 hours?
Sir,
Option C.
Option C, intermediate acting.
Option C is the wrong answer. So then going to question 4. Question 4 to Novo insulin. Sanofi insulin.
Sanofi insulin, sir.
Sanofi insulin. So Sanofi insulin. So insulin promotes all but which of the following? Lipolysis, lipogenesis, protein synthesis, glucose entry into cells.
Sir, it is A, lipolysis.
Lipolysis. Your answer is lipolysis?
Sir, protein synthesis. This is the C, protein synthesis.
Protein synthesis. Okay. So protein synthesis is the wrong answer. Okay. Lipolysis is the right answer. So coming to question number 5. Novo insulin. So Novo insulin. So regular insulin is used to provide the diabetic with a baseline insulin level, used in insulin pump to decrease blood glucose, provide insulin to cover increased blood glucose associated with meals, help control blood glucose during the night. Very easy question for you.
Sir, option B, I think.
Option B. Option B is the wrong answer. Regular insulin is not used in the insulin pump. It is the ultra short acting insulin that is used in the insulin pump. Either your aspart or your dispro insulin. Either of these two used in the insulin pump. So it provides cover, increased blood glucose associated with meal, regular insulin. So very
question chilo. স্যার একটা কোশ্চেন ছিল স্যার, আপনি ওই রেগুলেশন গুলো দেখানোর সময় দেখিয়েছিলেন +5 একটা আছে, তো মানে পরবর্তী কোন রাউন্ডে কি বোনাস কিছু আছে? কারণ আপনি
বোনাস না, হাফ অ্যানসার যদি দাও তাহলে 5, আর যদি ফুল অ্যানসার দাও তাহলে 10।
ওকে, বোনাসের কোনো অপশনই নেই?
না, বোনাসের অপশন নেই।
ওকে,
so because it is online, so I can't give any bonus. Very difficult to manage the show. So coming to next, Sun Arian. So form of insulin that have long duration of action are most commonly used to control fasting blood glucose and the levels that are present in between meals. Which of the following insulin formulation has this pharmacokinetic characteristic? Team 5, Sam Arian. Your time.
Sir, regular insulin, option D.
Option D, regular insulin, no. You know, you have to control the fasting blood sugar, you need long-acting insulin, and answer is insulin glargine. So with this, I think the round 3, we have completed the round 3. So Mita?
Sun Arian is on 10. All the other groups are on 20.
Okay. So there may be a tie. Okay. So
reverse যাবেন?
Huh?
Reverse যাবেন?
Reverse, okay. I'll go in reverse. So team round হয়ে গেছে, so we'll go reverse. So team 5, Sun Arian. I'll start with Sun Arian. Sun Arian. What is the instrument is testing?
Sir, diabetic neuropathy.
What is the name of the instrument?
So that I don't know, but I think it is diabetic neuropathy testing.
So it is not neuropathy testing. Yes, it is a neuropathy testing, but a part of neuropathy testing. So I'll give 5 marks to you because you have not said the name of the instrument, and second, it is testing basically the vibration. So you have to say vibration. So coming to the second, team 4, Novo Insulin. What the instrument is used for and testing for? Novo Insulin. Novo Insulin.
Glucometer.
Glucometer is the wrong answer, 0. So it is for the measurement of blood pressure. It is used for peripheral vascular disease, to test for peripheral vascular disease, or you can say ABPI. So next is the Sanofi insulin. Question number 3. What the doctor is checking in a diabetic and name the instrument. Two part of the question. So 5 marks, 5 marks. What the doctor is checking in a diabetic and name the instrument.
Sir, diabetic retinopathy, and maybe the glaucoma testing is doing.
Okay, so your time is up. So I'll give you 5 marks. Yes, they're checking diabetic retinopathy. That is true. Name of the instrument is ophthalmoscope. Okay. So coming to team 2, Novo GLP. What is the name of the instrument? If you give half name of the instrument, I'll give 5 marks. If you give full name of the instrument, I'll give 10 marks.
Sir, I think it's a food taster.
No, you will get 0. So it is basically.
Sir, can you tell?
Your time is up. So it is basically.
No, I am from Sanofi insulin, sir.
You can tell, but without any bonus marks.
Without any marks.
It's a monofilament.
All of you should sit together. You cannot say one, then another. That it is not accepted.
Okay. It is monofilament, sir.
Yes, monofilament.
Testing diabetic peripheral neuropathy.
But you should sit together. You are basically separated, so that is why it is difficult for you to give the answer. You should sit together always in the quiz. So coming to the next. Only BI Jardins. Okay. So BI, next question. This is Simis Winstein monofilament. So next question. what is being tested, and name the instrument. So there are basically two questions. So 5 marks, 5 marks. What is being tested and name the instrument.
Harris mat test.
Harris mat, yes.
Harris mat.
5 marks.
They are testing the pressure of the foot actually.
Yes, very good. 10 marks. So 5 plus 5, foot pressure and Harris mat. Right. So pressure points and Harris mat. Good. So Mita, please unmute yourself.
Yes, BI Jardiance is on 30, Novo GLP on 20, Sanofi insulin on 25, Novo insulin on 20, and Sun Arian on 15.
Okay, very good. So there's some differences.
Yes.
So now coming to your next question, complications, round 5. So we'll come with Sun Arian. So first question, a type 1 diabetic girl is slow to respond to question and slightly confused. No glucometer is available to check sugar instantly. What is your first priority? People know that you are from medical industry. So now give her the orange juice, give her insulin, call the doctor, observe her for 30 minutes, take her to nearby hospital. What you will do?
So give her orange juice. A.
Okay, very good. Okay, right answer. Right answer. Timerটা ভালো কাজ করছে না আবার এটা আবার ইয়ে Okay, next is Novo insulin. Which cancer risk increases in fibrocalculous pancreatic diabetes? Pancreatic cancer, liver cancer, prostate cancer, endometrial cancer, colorectal cancer. You know, insulin is the treatment of choice in fibrocalculous pancreatic diabetes also.
So A.
A is the right answer, pancreatic cancer. Very good. 10 marks. Next, Sanofi insulin. Polyphagia refers to weight loss, elevated hunger and eating, frequent urination, elevated thirst, increased blood sugar level.
The B. Elevated hunger and eating.
Okay, B is the right answer. Fourth is the Novo GLP. With regard to microalbuminuria, which one of the following statement is false? Please remember, false. Microalbuminuria refers to detectable but low concentration of albumin in urine. Lack of microalbuminuria does not exclude renal disease. Microalbuminuria is a marker of increased risk for cardiovascular disease. All patients with microalbuminuria will progress to more advanced stages of CKD or chronic kidney disease.
Sir, I think the right answer is C. Microalbuminuria is a marker of increased risk of cardiovascular disease.
Okay, so the answer is wrong because microalbuminuria is a marker of increased cardiovascular disease. This is the right statement. Lack of microalbuminuria does not rule out renal disease. Sometimes renal disease don't have microalbuminuria, and it is always refers to a very small amount of albumin in the urine. But if there is a microalbuminuria, all patients don't progress to end-stage renal disease. Only a small fraction of the patient ultimately lands up into end-stage renal disease. So the right answer is D. So next question to BI. BI too. Next question to BI.
Yes.
What is a common precipitating factor for tissue damage in ischemic foot? Bony fracture, minor trauma that is from ill-fitting footwear, arterial embolism, raised cholesterol, hypoglycemia.
Arterial embolism.
What is the answer?
Sir,
arterial embolism.
Sir, option C.
Arterial embolism.
Arterial embolism.
Wrong answer. the minor trauma is the right answer because of ill-fitting shoe. So this is the most common precipitating factor for the tissue damage. That is why we always ask our patient to take good care of the feet. Arterial embolism is not in the hand of the patient, but taking good care of the feet is in the hand of the patient. So coming to next round. Now, what is the score, Mita?
Yes.
Mita score? Hello.
Hello. Hello.
Mita is not there, right?
Not there?
I think connectivity is lost. Hello. I'll post you with the scores. You please proceed, sir.
Okay. So, okay, next round is pictorial round. So I'll start with Sun Arian. So name the manufacturer. Sun Arian. What is the time?
রাখছিলাম তো আমি তো একটু রেখেছি লাস্ট রাউন্ডে লাস্ট দুটো কি হয়েছে বলো লাস্ট দুটো আমার কাছে নেই জিএল 25 30
টাইম
মাঝখানে একটা কি হয়েছে
So non-Arian, no answer.
Sir, Lily said I said Lily, sir.
Huh?
I said Lily, sir.
Lily. No, Lily is not the right answer. So it is the first insulin bottle or the first kind of insulin bottle. It was basically prepared by the University of Toronto. You can see now, you can see University of Toronto. Okay. So second question will go to Novo Insulin.
হ্যালো স্যার আমি তো লগ অফ হয়ে গেছিলাম আচ্ছা রাউন্ড 5 এর লাস্ট আনসার লাস্ট বিআই জার্ডিয়ান্স পেয়েছিল 10
না পাইনি
ওকে আর তারপরে রাউন্ড 6 এর সান এরিয়ান
পাইনি
এটা পাইনি
আচ্ছা এবার নোভো ইনসুলিন হচ্ছে তাই তো
নোভো ইনসুলিন
এই রাউন্ডের একবার স্কোরটা বলে দিন
রাউন্ড 5 এর পরে এর স্কোরটা বলে দাও
আচ্ছা BI Jardiance is on 30, Novo GLP on 20, Sanofi insulin on 35, Novo insulin on 30, Sun Arian on 25.
Okay, so Sun Arian is 0 with this round. Next question goes to Novo insulin. Name the animal and the medicine derived from this animal. So 5 plus 5.
Start extending.
Novo insulin. Very easy question for you.
No, it's easier for Novo GLP.
Don't say. Okay, 30 seconds over.
Is it chameleon?
Yes.
I don't know medicine derived from this animal. I know the name only.
It is not chameleon.
It is exactly not chameleon. Okay, so your marks is actually 0. So this is basically Gila monster, and is the GLP-1 is derived from it. The first GLP of this exenatide, exendine, you can say. That comes from the Gila monster. Anyway, so this is Novo insulin. Then Sanofi insulin. Name the boy. You should not take more than 5 seconds time.
Sir, Leonard Thompson.
Yes. So 10 marks to Sanofi insulin. Coming to Novo GLP. Which medicine is produced from the tree Melas pumila? Novo GLP. Malaspumila. Novo GLP?
Yes, sir.
Name the medicine.
Sir.
Sir is produced from here.
No.
Okay, time up, Sanghamitra. So I think time is up, and this is apple tree, you can see.
Yes.
And from the apple bark, it is the fluorescein came out, and all the SGL2 inhibitors are basically started from here.
Shit.
Again, coming to BI. Last question to BI. Which medicine is produced from the plant Calagia officinalis, French lilac? BI? Koi?
Sir, metformin.
Yes, metformin is the right answer. Metformin is the right answer. Okay, so BI 10. Mita, score.
BI Guardians is on 40, Novo GLP on 20, Sanofi Insulin on 45, Novo Insulin on 30, Sun Arian on 25.
Okay, so it means that the highest mark is Sanofi Insulin, is it?
Yes, 45.
Okay, so Sanofi.
And then it's BI Guardians.
Then BI Guardians. And third is Novo Insulin.
Novo Insulin.
Yes. So this is the team. So Sanofi Insulin is 1 and BI is 2 and Novo Insulin is 3. Am I correct, Mita?
Yes.
Okay.
Absolutely, sir.
So congratulations to all the teams. You have done a great job and thank you very much. And over to you, Shomu.
Before giving this quiz, I have a question to the quiz master. Name a conference where everyone in the audience is bald. They do not have hair on their anybody's head.
Everybody is bald.
Everybody.
I don't know.
ENDIAB 2022. If you enter into Soumyabrata's portal, you would see that all the seats are full.
I can't see anybody.
You cannot. But yesterday, someone pinged to me that this conference is great, but I do not understand why every participant in the hall is bald. If you go through the participant link, you would see all the chairs are full, but none of them have hairs on their scalp.
Okay.
So it has been a fantastic day, and it's a very competitive span of quizzing, and we have seen reversal of fortunes with initially 3 of the teams going together and then somebody breaking loose. However, this time we would be able to give you your trophies from my office after about a week's period, because we are planning to do your certificates also with your pictures. So we will be collecting your photographs. There would be participation certificate for all the finalists, and the champions and the runners trophy, and the champions and runners certificate for BI as well as the Sanofi Insulin team. Thank you so very much for being with us, and it would be nice if...
sir. Sanjeev here from Odisha, Bhubaneswar.
Sorry?
Anyone telling anything? So thank you everyone, and we will be back with the main conference from 6 o'clock, where we will start with today's program, the scientific agenda of today, which includes the Charles Best Memorial Oration, which will be delivered by none other than Professor Subhankar Chowdhury. We would request those who are free, if you could join, it would perhaps a question or two might come from his talk in the next year. Thank you so much.
Thank you.
All of you.
Thank you, sir.
Thank you. Sanghamitra, you can run the loop, please.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Lake Town Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy Ghosh and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gongopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Lake Town Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Chaudhuri, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really, really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic fees over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy Ghosh, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Laketown Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Santosh, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really, really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference.
And this year's program has been very well balanced between not only addressing different aspects of management of diabetes, starting from very basics to the most advanced, most recent, and also devoting a significant amount of time to discussing endocrine topics, which would be of significant relevance to physicians overall. So I wish this program all success.
ENDIAB Summit will be organized by Lake Town Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Chowdhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship.
So don't miss it, ladies and gentlemen, and welcome once again.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata. Once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
Hello friends, this is Dr. Sujoy, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza.
It's a great pleasure that End Diabetes Summit 2022 will be held this year also, organized by Professor Anirban Majumdar and his group. Though it will be on digital platform from 11 to 13 February, but I'm sure there will be very good discussions, talks and lectures which will be delivered by many eminent diabetologists and endocrinologists. And this type of conferences and meet are very important for doctors because they have got scope to interact and even share their experience also in the practice of diabetes and endocrinology. And again, I express my pleasure for this scientific conference, and I wish this conference a great success. Thank you very much.
Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times.
কিসের ফোন জেনে নাও
Good evening and warm welcome to the second day academic feast, the ENDIAB Summit. And today I have really fascinating series of talks. And the first one will be none other than Dr. Soumyabrata Chowdhury, probably the key person behind the Lake Town Synergy and this ENDIAB Summit. He's a physician, consultant, diabetologist attached to multiple city hospitals and having numerous research publications. His special focus area being the incretin-based regimes. He has got pioneering work in collaboration with many stalwarts. A very well-read, very cooperative physician, a ready reckoner to a lot of us. It's always a pleasure to hear him. Over to Shomo for the first talk of the evening. And we'll be looking forward to hear how he addresses the challenge of persisting hyperglycemia. Over to Dr. Shomo.
I would, at the onset, like to thank the organizers for organizing such a wonderful event. And today my topic starts as tackling the challenge of managing persistent hyperglycemia in type 2 diabetes patients. I would walk the talk as long-term durable glycemic control, how it's a difficult goal to achieve, guideline recommendations and steps to achieve the glycemic control, considering why we should consider a DPP-4 inhibitor as an effective add-on therapy, for example, vildagliptin, and why we would also consider it safe, and then would like to summarize the entire. So, as we all know, that 76.6% of type 2 diabetic patients in India have poor glycemic control. Despite the presence of guidelines, now India-specific guidelines, despite the presence of well-defined treatment in majority of the people, the disease is poorly controlled. Long-term durable glycemic control, again, is a difficult goal to achieve. So what does RSSDI, the Indian body, set as guidelines? They say that if glucose targets are not achieved with 2 agents, start third oral agent, which is either a DPP-4 inhibitor, alpha glucosidase inhibitor, SGLT2 inhibitor, or TZDs, depending on the second line agent already being used. Again, like the American Diabetes Association, they have put in a line for starting insulin or GLP-1 agonists. The ultimate goal they have set is achievement of glycemic control with minimal side effects, for which there are 2 steps: the setting up of individualized glycemic targets, and step 2, choosing the right add-on. So how to set individualized glycemic targets? This is the cornerstone of managing type 2 diabetes as per RSSDI guidelines 2020. Fasting plasma glucose should be ideally between 100 and 125. 2 hours plasma glucose during 75 grams oral glucose tolerance test should be 140 to 199, and A1C should be 5.7 to 6.4. Glycemic targets must be individualized, and in the process of individualization, it should involve a shared decision making where the patient is also a part of the decision taken about his treatment. The ADA 2021 approach to individualization of glycemic target says that good glycemic control is reflected by A1C, which remains the foundation of managing type 2 diabetes. A reasonable A1C goal in an adult with type 2 diabetes is less than 7. Individualized approaches play a vital role in preventing or delaying the onset and progression of diabetes complications. However, here we should definitely add that today a different concept, something beyond A1C, something beyond the glycemic triad is being discussed well. And yesterday you have heard Dr. Shomik Goswami talk about time in range. Again, time in range that is between 70 and 180 should be for 70% or greater time of the day. And well, however interesting and however insightful it might look, till today, measuring time in range in clinical practice is expensive and the devices are not accessible. So for the time being, I think we have to stick to HbA1c till time in range is more established and the devices by which we can look at the time in range become more accessible and affordable for the care provider. So how do we choose the right add-on therapy to help patients reach their glycemic targets? The therapeutic armamentarium of oral anti-diabetic agent has expanded its horizon. Sulfonylureas in 2005 and now in 2020 we have 7 major classes of OHs including DPP-4 inhibitors and SGLT2 inhibitors. With the increasing number of available medication choices for diabetes, patients are being managed with a greater number of classes of medications in combination. But yet in India, if we have a look at the data, we would see the first 5 combinations with metformin are different forms of sulfonylurea, and the glimepiride sulfonylurea, economically speaking, they have captured 1/4 of the oral anti-diabetic combination therapy market. So what are the considerations when you choose an add-on based on outcomes and adverse effect? The immediate outcomes being glycemic control, body weight, lipid levels, LDL, HDL, cholesterols, and triglycerides. For example, the long-term outcomes would talk about cardiovascular risk and mortality, the microvascular outcomes, and also the all-cause mortality. And the adverse effect would consist of the GI intolerance and of course the hypoglycemia, and the epitaph of everything would be severe and nocturnal hypoglycemia. So while we address the complexity of choosing the most effective add-on therapy for a type 2 diabetic patient and controlled on a sulfonylurea metformin combination, that being the most predominant combination being used in India, so what would be the characteristics? The effectiveness of an add-on to sulfonylurea and metformin can be considered based on whether it can achieve glycemic goals. Is titer control beneficial and can it be achieved without an increased risk of hypoglycemia, especially amongst the elderly? And will the treatment improve the beta cell function and thereby improve outcomes? RSSDI 2020 regarding triple therapy talked about patient-centric approach, and they said that if glucose targets are not achieved with 2 agents, a third oral agent may be tried, and I have talked about this in a previous slide. The various choices for an add-on oral therapy could be after sulfonylurea and metformin, could be DPP-4 inhibitors, SGLT2 inhibitors, TZDs, and AGIs. Now let's see a comparison between them. If you look at DPP-4 inhibitor as an add-on oral therapy over TZDs and AGIs, we would see the key advantage over TZDs and AGI is the highly favorable tolerability and weight neutrality. So DPP-4 inhibitors here fits the bill of an effective yet safe therapy. When choosing an add-on, the clinician's mantra should be prius minus nocere, which means first do least harm. The key advantage of DPP-4 inhibitor over SGLT2 inhibitor is its highly favorable tolerability. You don't have to really look at UTIs, GMIs, etc., about postural hypotension, about the chances of limb amputation. And so the DPP-4 inhibitor is just like a fill it, shut it, and forget it drug. And thus is an effective yet safe therapy, especially among patients on polypharmacy. So why do we consider a DPP-4 inhibitor as vildagliptin as an effective add-on therapy? Vildagliptin, as we see that it significantly improved glycemic control in patients with type 2 diabetes, inadequately controlled with metformin and glimepiride combination. The mean change in A1C was greater with vildagliptin compared to placebo. HbA1c reduction was 1.01. and the treatment difference was statistically significant. And if you looked at patients who achieved their glycemic targets when vildagliptin was added on to sulfonylurea, was in overall population, it was jumped from 5.6 to 28.3 with a vildagliptin 50 milligram twice daily, and for whom the baseline HbA1c was less than 8%, it was an increment of 13.9 to 38.6%. In triple combination with sulfonylurea and metformin, it showed clinically relevant HbA1c reduction of about 1% and robust fasting plasma glucose reduction of about 1.1 millimoles. Patients on vildagliptin also showed improved beta cell function, improvements in the AIR glucose and A index, increased disposition index by 69% indicate improvement of beta cell function with vildagliptin, and there has been nearly 5-fold enhancement of beta cell function when vildagliptin was added to metformin. Vildagliptin thus can be said to enhance beta cell secretory capacity, and thus it ticks all the boxes for an effective and well-tolerated add-on therapy. Efficacy as an add-on therapy by HbA1c reduction, improvement of beta cell function, and effective and safe in the elderly. So that is about efficacy, and let's look at safety. Moving beyond glycemic control, the RSSDI 2020 guidelines talked about patient-centric, evidence-based approach for management of type 2 diabetes, and the safety profiles to consider consist of the weight impact, the hypoglycemia risk, and also keep in mind the considerations. The vildagliptin in triple combination is weight neutral and associated with a low risk of hypoglycemia, as is seen by the mean change in body weight is less than 1 kg. It's about 500 grams, and only 5.1% patients said to put on the weight, and lower risk of hospitalization due to heart failure with vildagliptin in comparison with vildagliptin, saxagliptin, and sitagliptin. This is a study by in the International Journal of Heart Failure from Chang et al. But it's a little bit debatable with a real world evidence of about 2.39 lakhs. Vildagliptin had 0.74 as a hazard ratio, and the upper bound of the confidence interval was 0.81. However, it is not supported by the cardiovascular outcome trials, as sitagliptin proved to be neutral in TICO's trial, and saxagliptin had a 1.27 hazard ratio with regards to hospitalization due to heart failure, and vildagliptin for itself did not have a cardiovascular outcome trial. No change on left ventricular ejection fraction with vildagliptin. This is from the VIVID trial, where although the end systolic and end diastolic diameters, they did increase without decrease in left ventricular ejection fraction with vildagliptin in comparison to placebo. These are the summary of the key cardiovascular evidence on vildagliptin this is the second one is the VIVID trial, and it got the 254 patients, Schweitzer et al., 25 phase 3 trials, greater than 13,000 patients, and McInnes et al. In 2015, 40 phase 3 and 4 trials with 17,000 patients, Chang et al. With greater than 2 lakh patients, that's the real world evidence that I talked about. Williams, 7 lakh patients. Vildagliptin showed no increased risk of adverse cardiovascular events compared to the anti-diabetic drugs. And then Fadini et al., 17,000 patients, no difference in incidence rate of first and total hospitalization heart failure events with vildagliptin compared to sulfonylurea. Vildagliptin thus ticks all the boxes as a safe add-on therapy, as it had recorded low hypoglycemia events. It is weight neutral, and even without a CVOT, with such robust numbers being included in the real world evidences, it can be said to be CV safe. And also in low ejection fraction with NYHA scores of 1 to 3 in the VIVID trial, it showed that addition of vildagliptin did not alter the LVEF in any way. So we can consider a DPP-4 inhibitor like vildagliptin as an effective and safe add-on therapy across various patient populations, especially in the elderly and in the renally impaired. Vildagliptin was effective and well tolerated in elderly type 2 diabetes patients, and elderly patients with a mean age of 77 years were on vildagliptin add-on therapy showed a relevant HbA1c and fasting plasma glucose reduction. HbA1c reduction in the age greater than 75 years was 1.08%, and the age less than 75 years was 0.9%. Fasting plasma glucose was reduced by 1.24 and 1.36 millimoles per liter, respectively. And if you looked at fasting, HbA1c, and the body weight, and looked at hypoglycemic events, if 0.9 to 1.2% A1c reduction, 1.1 to 1.2% of fasting plasma glucose reduction, and body weight reduction by 900 grams and 0.4. Most importantly, body weight did not increase. Hypoglycemic events, very important, any events less than 75 years, 0.3%, negligible, and in greater than 75, it was 0%. And if you look at the severe hypoglycemia, that was the concerning for us, that is 0% in both the age groups of greater than 75 and less than 75 years. So adjusted HbA1c and mean change from baseline from week 24 and 52 in patients with moderate and severe renal impairment receiving vildagliptin or placebo. So this is the moderate renal impairment in the left-hand side. And as we can see that the adjusted mean change is more than in the vildagliptin group rather than in the placebo group, and the between group difference is statistically significant in the severe renal impairment group, where the vildagliptin reduced it by about 0.9%, and in the placebo group there wasn't a statistically significant reduction. But we must remember that below an eGFR of 50, vildagliptin has to be used as an OD dose. So vildagliptin is safe as an add-on for type 2 diabetic patients with moderate and severe renal impairment. None of the adverse events were severe, suspected to be drug-related, or led to discontinuation. So if you look at moderate renal impairment, you would see that any adverse event, any severe adverse event was comparable in the vildagliptin 50 milligrams group versus the placebo group, of course 50 milligram once daily, and any adverse event leading to discontinuation was 4 in the vildagliptin group, and in the placebo group it was 7, and deaths were similar, 1 and 1. And in the severe renal impairment group, well, you had 72.6 adverse events in the vildagliptin group and 74.2% adverse events in the placebo group. Severe adverse event was 23 versus 20. Any adverse event leading to discontinuation was 11 and 6, and deaths were 3 and 4 respectively, a little bit more in the placebo group, but not statistically significant, however. So vildagliptin again ticks all the boxes as a safe and effective option for add-on therapy across patient population. And in summary, we can say the advantages of add-on vildagliptin. We all know from the verified trial that vildagliptin and metformin, if we use it in the beginning, at the start of the disease, it had immense benefits. We have all discussed it and listened to it in several CMEs before coming out here. But here we have discussed vildagliptin as an add-on to sulfonylurea and metformin. It showed better efficacy, beta cell preservation, safety profile with low risk of hypoglycemia, natural weight on weight gain, neutral effect on weight gain, well tolerated amongst elderly patients with cardiovascular disease, renal impairment. And in conclusion, we can say, despite good initial efficacy of dual combination of sulfonylurea and metformin, sulfonylurea failure is a known issue. Many patients require an additional add-on therapy over a period of time. And as we discussed, that about 75%, more than 75% do not achieve targets. DPP-4 inhibitor as a second add-on therapy can achieve significant glycemic improvement. And here we have to remember, the later we add the drug, usually the HbA1c benefit or the reduction benefit goes on to be less. But vildagliptin, despite being put on as a second add-on to metformin, first add-on being sulfonylurea, had produced nearly about 1% of HbA1c reduction. It is more effective DPP-4 inhibitor amongst all gliptins when used in twice daily dose. That is how some of the studies put it. And vildagliptin as an add-on to metformin and sulfonylurea was found to be effective and safe even in Indian patients. That is very reassuring that in the genotypes and the phenotypes that we treat, it has been effective as an add-on to the most widely used combination therapy, that's sulfonylurea and metformin. So in clinical practice, probably we are likely to encounter somebody on sulfonylurea and metformin failing to achieve targets coming to us. And there, vildagliptin, with the data that I had presented, presents itself as a safe and efficacious therapy as a second add-on, and is usable even in elderly subjects and in patients with renal impairment. But it is to be remembered that in patients with renal impairment of eGFR less than 50 ml per minute, it is to be used as once daily. Thank you so very much for your kind attention, and I would be happy to take in questions.
Thank you, Shomo, for such a lovely session, for such a lucid talk. Probably one thing coming up, that despite of not having a dedicated cardiovascular study, vildagliptin has probably established its place over last 12 years of clinical usage. Would you like to re-emphasize this issue that we often look for CVOT data and we often look for CVOT safety cum superiority data while choosing any molecule? But we've been happily using vildagliptin over last decade, even without any dedicated CVOT thing. Though we had some pooled EMA data regarding vildagliptin. What will be your comment on this thing? The requirement of CVOT for all molecules.
Actually, we had started to use vildagliptin and even before the other CV outcome trials had come to the market. And with our regular use, I was not possibly practicing diabetes at that point of time. It had gained the confidence of our peers and stalwarts of the field, due to which, even without CVOT data, due to its efficacy and convenience of usage, due to its the DPP4 characteristic of being a fill it, shut it, and forget it nature. And most importantly, what I emphasized in the talk, that even after addition to sulfonylurea and metformin, which was possibly the commonest OAD combination that the patients were on at that period of time when vildagliptin and sitagliptin had come into the market, they had produced enough of A1C reduction. And as we know from the UK PDS, which is the Bible of type 2 diabetes, that HbA1c reduction can result in some benefits, whether it be microvascular, which is evident pretty early on, and later on we came to know that yes, if you follow up the patients for long enough time, a good HbA1c reduction being in control does produce macrovascular events as well. And to be frank, I think Professor Majumdar is also there. Despite without being a CVOT savvy DPP4 inhibitor, really did we see many heart failures due to a DPP4 inhibitor in our clinical practice? You are also there. Please comment. How many? How many did you see?
Somo, I fully agree with you. Our personal opinion or our current understanding about this molecule, and we are using this drug for almost 15 years, and we have rarely seen any precipitation of heart failure with the use of vildagliptin. On the other hand, I can vividly remember some of my patients who developed heart failure after the rosiglitazone therapy. So we can definitely clinically distinguish with our experience that vildagliptin appeared to be very safe. Having said that, there is some question is raised because of the fact, in the VV trial, we have found that there is somewhat increment in the left ventricular volume. But we don't.
But without any impact on the left ventricular ejection fraction.
Without any impact on the left ventricular ejection fraction. But we don't know the significance of the increase in the left ventricular volume. As far as the heart failure data and the data what you have shown, that it has decreased the heart failure issue, even with compared to the sitagliptin.
Well, I did not. This is a company presentation, and I given my disclaimer that this is contrary to the.
But this kind of data is there. I am not telling the data is not there. Data is there. Also, the reverse data is also there. That as a group, the DIP4 inhibitors have shown some increment in the heart failure. So there is a little bit of controversy, though the sita and the linagliptin has actually cleared doubt because they had done a dedicated cardiovascular outcome trial. We have seen somewhat increment in the heart failure risk, though not statistically significant with allogliptin. So as a matter of fact, the heart failure issue is still with the DIP4 inhibitor. So vildagliptin, as because
even the one aid to you, if you really look at the real world evidences, and if you look at the distribution of the real world evidences, the Italian data real world evidence which came out, which showed that there is no increase in heart failure with any one of the gliptins. However, once you're including the American data, perhaps you are having an incidence of heart failure. Why is this difference? I fail to understand.
Probably the definition is not uniform. Probably the definition on cutoff is not uniform.
Ajay has rightly pointed out that may be the answer, because you can see that in the heart failure, whatever the study, the definition of the heart failure in different study is different. Well, if I remember correctly, in one of the study they have taken the heart failure if it is observed or if it is actually recorded in the emergency. That's it. There was no need to look into at this.
I know there was no biochemical or echocardiographic.
BNP was not included.
Yeah, at that point of time,
BNP was not included in many of the studies.
Was not actually taken as a important surrogate marker as far as the heart failure is concerned, the diagnosis is concerned. So we are really a little bit doubtful. But Shomu, I think we have one question in the chat box, and that is very important. That where you will not write vildagliptin. So do you have any area of concern where you will not write it? Because you know that the physicians want to know this, that they often write vildagliptin with the understanding that it is one of the safest molecule we can write as far as the diabetes management is concerned. But we must know that where is your concern?
There are two things that I would like to reiterate. If the LNI, SGOT and SGPT is more than 3 times the upper bound of normal, that is a contraindication that's included in the PI also, I suppose. And second, regarding the dosing, I have repeatedly said that once the eGFR is less than 50, vildagliptin should be used once a day. And now with the availability of the OD formulation, perhaps 50 OD could be a choice. And in such a scenario.
Okay, so I think
anyone having a history of diarrhea with a reason to suspect pancreatitis, or a young person where I'm excluding gallstone or pancreatic disorders, I would be double cautious. I should be double cautious. Whenever I'm listening something suggestive of pancreatitis, using incretin-based regime would definitely put me at risk. I would like to have a very quick questions to Dr. Anirban Majumdar, because it's always very enriching experience to hear him. Very two quick questions. Number one, we all know that these molecules are going off patented and lot many congeners are coming up, both gliptins as well as SGLT2 inhibitors. Are we seeing the next phase of clinical prescription where we are keeping sulfonylurea aside because of the economic version of gliptin and DPP4 inhibitor, along with SGLT2 being now available as a very affordable minimum? And so, second question is, where do you put DPP4 inhibitor in quote unquote SGLT2 era, or peptide in a pill era, the way you define it?
Yeah, I think giving you the answer to the last question is that it is just price issue. Otherwise, you can write DPP-4 inhibitor or the oral GLP-1. So where the patient actually can afford, and GLP-1 definitely will be better because it will have
The physiological advantages beyond the physiological limits.
and also the cardiovascular benefit. So GLP-1 definitely better than the DPP-4 inhibitor, as a matter of fact. Now the price is basically true. But coming to your first question, I'll give you a brief understanding that how we are managing diabetes nowadays and how we would like to see it to be managed by the physicians. That from the very beginning, it is better that we actually try to cover all the 8 pathophysiological defects of the diabetes. So when a diabetic patient come to us, then usually nowadays for the last few years, I have started using all 2 or 3 drug agents simultaneously. And therefore, when you are using 2 or 3 drugs from the very beginning, you should be very cautious about the hypoglycemia. So quite naturally, the sulfonylurea will not be one of the choice as far as this regime is considered. So either I'll give a metformin plus PIO plus SGLT inhibitor, or I'll give metformin plus PIO plus DPP-4 inhibitor, or I'll give metformin plus DPP-4 inhibitor plus SGLT inhibitor. So something like that. So 2 or 3 drug combination from the very beginning, which will not produce hypoglycemia. So therefore, as you have rightly pointed out, once all the major D4 inhibitors and the major SGLT inhibitors are off patented, the pattern of prescription I expect will change, and the physicians and those who are actually practicing in remote areas will be benefited, both as a patient and also as a physician, because they don't have to face the important issue, that is hypoglycemia, with the use of combination of 2 or 3 agents simultaneously from the very beginning. So I think Somo, Ajay,
Thank you so much, Anirbandha, for such a very nice thing. Can we request Dr. Soumyabrata to take over the session and request our next speaker? I think Dr. Rana Bhattacharya has already logged in. And can we move on to our next session?
Dr. Rana, but thank you, Ajada, for moderating the session and asking me so many questions, and many of them pertinent to our day-to-day practice. And I think we would just take a comment from a small bite about the conference from Dr. Sudeep Chatterjee before we move on to listen to Dr. Rana Bhattacharya, who is going to refute Dr. Majumdar and say what, how, and when we should use sulfonylureas in day-to-day practice.
Dear colleagues, thanks to some wonderful endocrinologists in the city of Kolkata, once again, we are privileged and blessed and indeed very fortunate to have another session of the Endocrine Diabetes Meet, this time virtual, but nevertheless as interactive and as informative as the sessions in the past. Good luck to all of you. Happy conferencing, and thanks to the organizers for making it possible.
So our next topic of today, role of sulfonylurea in management of type 2 diabetes in view of latest national and international guidelines. You just now heard how you could benefit from usage of non-hypoglycemia causing agents. You heard how you could add vildagliptin on top of sulfonylurea and metformin. And now you would hear the position of sulfonylurea today in the management of type 2 diabetes, irrespective of the fact that you have got DPP-4s, you have got vildagliptins, you have got SGLT2 inhibitors, you have now got peptide in a pill. Let us hear Dr. Rana Bhattacharya, who is MD MRCP and DM Endocrinology, and he's an assistant professor in charge of hormone assay lab, Department of Endocrinology and Metabolism, IPGMER, and SSKM Hospital. Received Dr. J.C. Patel and Dr. B.C. Mehta Best Paper Awards from Journal of Association of Physicians of India. Received ARCET Award from Endocrine Society of India, and more than 75 publications in peer-reviewed journals and book chapters. Over to you, Dr. Rana Bhattacharya, please.
Thank you so much. Just let me share my slide first. I hope the slides are clearly visible.
Yes, please.
Yeah. Thank you. Thank you so much, the organizers of the ENDIAB Summit, for inviting me here. And basically, my task is a bit difficult because, with availability of newer and newer drugs in every passing year, it's really difficult to place the various medicines to treat diabetes. On the one hand, it's a boon that so many drugs are available to treat our patient. On the other hand, it just makes the decision making more complex. Looking back, say around 20 years, then we had our metformin, the age-old drug, and along with that, again, old friends like sulfonylureas and insulins. Just gliptin just appeared in the horizon at that time. And subsequently, over the years, we have so many other drugs, both oral as well as injectable, including so many analogs of insulin. Now we have plethora of choice. But still, sulfonylurea, being kind of an age-old friend, is still useful in many patients with diabetes, and I know others will also agree that we do use this medicine on a day-to-day basis. But it's important to know how to place this drug for practical use. And we will today focus mainly on the guidelines, what the various national and international guidelines said, that's the topic that is given to me. But along with that, at least during discussion, we would focus on some practical aspects as well, taking from this guideline as well as from our personal experience with this drug, that how to use it practically in a given patient with diabetes. So this is the agenda of today's discussion. We'll just discuss a kind of overview, followed by the various global, national, regional guidelines, and we'll just look at the safety of sulfonylureas, and then how to implement sulfonylurea therapy in a patient-friendly way, and ultimately we'll discuss the positioning. This is something that we know very well, that with the years, the numbers of patients with diabetes are multiplying like anything. And it's when we define diabetes, there is a kind of harmonious recommendation from various world bodies regarding how to target the blood glucose levels, along with, of course, the other aspects which I won't focus today. And most of the guidelines said that fasting blood glucose levels should be targeted somewhere around 80 to 130. Postprandial, if we measure it by glucometer, should be less than 180, and A1C should be less than 7. And we also know that most of the guideline also calls for individualization of the target, particularly keeping in view patients' comorbidities, very other practical concerns, and the duration of diabetes, and so on and so forth. So depending on that, most of the guidelines says that metformin possibly should be used as a first line, with some rare exceptions in some situation where metformin cannot be tolerated, or some situation where there can be extra other risks where metformin is contraindicated or other drugs are preferred. Now, if we look at the sulfonylurea, we know that as a kind of oral agent, this is one of the possibly most prescribed oral anti-diabetic drug used in our country. And mechanism of action, we all know that it stimulates the release of insulin from the beta cell of the pancreas by binding with potassium ATPase channels. And there are various kinds of classification of various generations of sulfonylureas. Nowadays, we mainly classify it as first generation versus second generation. There are older generations as well, but by modern sulfonylureas, we usually mean drugs like glimepiride or gliclazide. And we all know that this sulfonylurea class of drug have a very efficacious kind of profile. Now, sulfonylurea, because of its efficacy and relatively lower cost, it was included in various lists of essential medicines across the world. But of course, there are some variation regarding which sulfonylurea is preferred over the other, particularly the difference between glimepiride and gliclazide are there depending on the country and the region. Now, if we look at the global guidelines, there are hosts of guidelines. Of course, I won't bore you with all the details of this. I will focus on few of the important points that where the sulfonylurea is placed in this guideline. Starting with possibly one of the most popular ones, that is American Diabetic Association, which publishes its guideline every year in the month of January. They ask to consider sulfonylurea when the patient is uncontrolled with metformin, or the target, the actual A1C is such that it's way beyond the targets, and with a single metformin, you would possibly will be unable to control the blood glucose level. So in that case, you can start with combination and you have multiple choices. But of course, there are some specific recommendation of sulfonylureas, like when the cost is a major issue, they advise this as a second line in addition to metformin. In patients without cardiac and renal problems, they say it is preferred, but it is not contraindicated in those patients as well. And as a third line therapy in a patient who has atherosclerotic cardiovascular disease or CKD, because now we have some drugs which, in addition to glycemic control, targets this particular organ damages. So therefore, ADA has placed sulfonylurea after such drugs like SGLT2 inhibitors or GLP-1 analogs. If we look at the recent International Diabetes Federation or IDF guideline, they said that sulfonylurea can be prescribed as a first line even when the metformin intolerance is there, but they of course ask to use the modern sulfonylureas in preference to older ones like glibenclamide. And metformin can be used as a combination of sulfonylurea. Again, they recommended the modern sulfonylureas, and they also recommend whenever you use sulfonylurea, although the modern sulfonylureas has relatively lower risk of hypoglycemia, but nonetheless, you should make the patient aware about how to recognize and self-treat hypoglycemia. So these are the recommendation from IDF. Moving over to another guideline, that is from NICE. This guideline particularly says that, again, it's NICE guideline is more or less similar to the IDF. This NICE guideline is based on UK, but the recommendations are broadly similar. They also said one additional point they have mentioned, that is a very practical one, I think. If the patient is very much symptomatic with hyperglycemia, of course we prefer insulin, but we can use sulfonylurea as well, because you know the sulfonylurea among all varieties can lower blood glucose level relatively very rapidly, and therefore for initial symptomatic management one can use sulfonylurea either alone or preferably along with insulin, and maybe basal insulin, because with prandial insulin sometimes it's difficult to use sulfonylureas. And of course, like other guidelines, they say that it can be used as a third line after metformin plus DPP-4 inhibitors or SGLT2 inhibitors. If we look at the ISPAD guidelines, which actually looks at the it's a international body of the diabetics involving the pediatrics and adolescent age group, and they recommended that in general sulfonylurea is not approved at less than 18 years of age. But again, this is possibly true with of course with type 1 diabetes, because you know no OAD is advised there in general, but also to that some type 2 diabetes patients as well. But we have experience with sulfonylurea in our day-to-day clinical practice with a relatively rare forms of diabetes like maturity onset diabetes in young and in neonatal diabetes. So this contraindication is not blanket. In selective patient population, we use these agents in childhood and adolescence and even in the neonatal age group. Although I know you physicians won't treat neonatal hyperglycemia, neonatal diabetes, but just to make a point that this is not an absolute contraindication. WHO also said that the sulfonylurea can be used as a second line therapy when the blood glucose is not controlled with metformin. And again, WHO also stated that gliclazide and glimepiride are preferred over the older sulfonylureas because of risk of hypoglycemia. If we look at the EASD and ASE guidelines, again, they have recommended use of sulfonylurea in selective patient population. Again, possibly in most of the situation as a part of dual or triple therapy particularly. And again, in a patient with high CV and renal risk, they ask it to use it as a third line agent. Now, if we look at the various national guidelines after these international ones, but again, I won't go into details and again bore you with those. But overall, as you can see, I will just move through these slides, that across the world, sulfonylurea is still in recommendation. And in India also, the ESI RSSDI joint clinical practice recommendation, which was published 2 years back, also said that sulfonylurea can be used as a second line agent in persons who are not obese. So in non-obese type 2 diabetes, sulfonylurea can be used as a second line individual and second line agent. And of course, they also said that glimepiride and gliclazide are relatively CV safe, so they can be used in a patient with CVD. And also they have mentioned that in DKD background, these drugs can also be used. But of course, with use of this drug, if it's preferable to use self-monitoring if possible, because again, possibly due to risk of hypoglycemia. The countries in Europe and also Canada, they also recommend the use of sulfonylurea as a second or third line agent. The same is true for other countries as well. I won't go into detail of this. Regarding the international task force recommendation, they said that I think these points are also mentioned in the previous guidelines, but they just summarized the whole thing in this way, that in the second generation drugs can even be used in a patient with background CVD, CKD, as well as elderly population, but with appropriate caution. Now, moving over to cardiovascular safety part. Now, let's see what the various guidelines say. Now, the advanced trial, this is now relatively a few years now, advanced follow-on study has also been published. This is not a kind of typical CVOT trial because, in CVOT trials, the main aim is to achieve glycemic equipoise so that the CV safety of a particular drug is tested against placebo. Although this equipoise is rarely achieved, in fact, all of the trials that have performed till date, in none of them, the equipoise was achieved. However, the advanced trial actually looked at the different things. They tried to look at the strict glycemic control with a target A1C of less than 6.5, which was achieved, versus relatively relaxed HbA1c control. And in a strict glycemic control, they have used sulfonylurea, particularly glycoside, in the intensive arm, and there was no excess cardiovascular events in those arm, those patients who were on sulfonylurea. So it's a kind of indirect evidence, you can say, although it's not a classic CVOT. The Carolina trial, the linagliptin was compared with sulfonylurea glimepiride as a background therapy. And this is a kind of active comparator CVOT, and it showed there is non-inferior CV safety of glimepiride in comparison to linagliptin. And therefore, a meta-analysis was done of Carolina and Carmelina. Carmelina is a placebo-controlled trial of linagliptin. So the authors tried to look at whether by this indirect comparison, the sulfonylurea glimepiride, whether it can be compared with placebo in terms of cardiovascular event. And they have shown that in terms of 3-point major adverse cardiovascular outcome, all-cause mortality, CV death, and non-CV death, the glimepiride is non-inferior to placebo. Now, regarding the other age groups like elderly and in the ASCVD, CKD, heart failure population, in all those patients, second generation sulfonylurea can be used, but as I've said, with appropriate cautions. Now, if we look at from the patient's aspect, now what important factors do we look at? Number one, of course, is the comorbidities, risk of hypoglycemia, body weight of the patient, the cost of the therapy, side effects, and ultimately patient preference. Now, if we want to individualize the type 2 treatment in countries like ours, the patients, sulfonylurea can be used as a cost-effective approach, but with appropriate caution regarding weight gain and hypoglycemia. And this hypoglycemia, as I've said, can be mitigated by proper education and with appropriate up-titration of dose, whereas the weight gain, it tends to stabilize after some initial gain in weight of around 2 to 3 kgs. The continuous weight gain, which is usually seen with insulin, is not seen with sulfonylureas. And some degree of weight gain may be welcome to some of the non-obese individuals with diabetes who many a times complains that আমার খুব রোগা লাগছে, আমাকে সবাই মিলে বলছে আমি রোগা হয়ে গেছি. So in those particular situations, sulfonylurea may actually help. In patients with renal impairment, of course, you should start with relatively lower dose of modern sulfonylureas. Now, keeping these practical points in mind, I think sulfonylurea can be used safely in these susceptible populations. Even in Ramadan, there are multiple recommendations and multiple studies around the world which said that during the fasting period, if we use newer sulfonylureas, there is the adverse risks of like hypoglycemia is really not very high. And the same thing applies for elderly as well. So overall, if we look at that during in the other patient population like pregnancy, of course, this is not recommended. In children and adolescents, I've already said in type 2 diabetes is generally not recommended, but we have plenty of experience with other kinds of diabetes in relatively young persons. In CKD, CVD, and we have already discussed. In liver disease, of course, in advanced liver disease, we should not use sulfonylurea because in advanced liver disease, the glycogen store is depleted. And if hypoglycemia occurs, it's very difficult to manage those hypoglycemia because they tend to be more severe. But with relatively milder liver impairment, like mild to moderate hepatic impairment, we can use sulfonylurea with appropriate cautions. Now, after all this, let's summarize how to position the sulfonylureas. As a monotherapy, we can use it if the insulin, if the metformin is contraindicated or not tolerated. As a second line, we can use that there is no background risk of CKD, ASCVD, heart failure, and of course, cost is a major issue, and patient does not have a very high risk of hypoglycemia. As a part of triple combination therapy, we often use this agent as it's a very efficacious one, and it can be used in addition to DPP-4, insulin, pioglitazone, and GLP-1 receptor agonist. Regarding insulin, I have said it once that it can be used with basal insulin in combination. With prandial insulin, we generally do not use it. We use it very rarely, but of course, we should use caution because it multiplies the risk of hypoglycemia if we use it with prandial insulin. And as a quadruple therapy, again, sometimes you all know we come across the patient who are very reluctant to take insulin, and you feel that patient is not very much insulinopenic. In some rare situation, you can use it as a part of quadruple combination therapy, although this is not something that we generally recommend. These can be used in some exceptional situations. In combination of insulin, we have discussed. In elderly population, we have discussed. Ramadan, CVD, we already discussed. So we use this sulfonylurea with appropriate cautions in this particular patients. To summarize, the sulfonylurea still continues to play a vital role in the management of type 2 diabetes mellitus, and the relatively the newer sulfonylureas like imipiride and gliclazide are relatively less expensive, and they have a less degree of hypoglycemia. Weight gain is also very minimal, and they do not have any cardiovascular toxicity. And majority of the trial across the world still prefer neo sulfonylureas, and they recommend continue using it, except the few situations I have said. And even in those situations, they can be used as a third line agent. So still, the countries like us, where many of the patients may not be that obese, and sometimes they need a cheap drug, and they need multiple weights sometimes. So in those situations, sulfonylurea definitely play a very important role in those patients with diabetes. Thank you all for your patient hearing. I would hand over to the organizers for further proceedings. Thank you again.
Thank you. Thank you so very much for your presentation. And just thank you for that wonderful presentation, reinstating the fact that we need sulfonylureas, but you have with the cricket matches that are on our delegates are probably in the mood of some googlies, here comes one for you. There are certain studies which say that gliclazide has got a lesser propensity of hypoglycemia than glimepiride. Does that distinguish your use between these two agents? This is the first question. Address.
Well, yeah, there are some studies, but practically the newer antidiabetic, newer sulfonylureas as such has lesser propensity of hypoglycemia. But of course, there are some studies which say that gliclazide has a lower hypoglycemic potential. So in a patients with particularly in elderly patients or patients with renal failure, particularly, that's a subgroup where possibly we prefer gliclazide to some extent. But otherwise, both of these drugs has a lower hypoglycemic potential. The glimepiride, one of the advantage maybe the multiple doses which can be used as a up titration. So we can use a very low dose of glimepiride if the patient is very prone to hypoglycemia. So, yeah, in particular renal failure, possibly, definitely gliclazide may be preferred.
You have already perhaps started to answer the second question, which called about the KDIGO guidelines and the use of gliclazide. And the third question, which is there, I think you take the unanswered part of the second question and the third question together. The third question is, what is the maximum dose of glimepiride that should be used in day-to-day practice?
Yes, the standard recommendation dose as per the prescribing information is 8 milligram. But we all know that beyond 3 to 4 milligram, the additional benefit is not there too much. But well, say if you see that after giving 4 milligrams, the blood glucose level is controlled, but you want a slightly better control maybe. So for this minor reduction of blood glucose, you may go on adding further doses up to 8 milligrams. But practically speaking, we very rarely use glimepiride beyond 3 or 4 milligrams. Very rarely, if at all.
Thank you so very much for your. And there is that age-old question which always comes, which has already come from 2 or 3 of our delegates, that in a scenario where the major gliptins are likely to be off patent and available at generic price in a couple of months' time, except for linagliptin, in a scenario where we have got generic DAPA, where exactly would you start a new onset diabetic subject? What would be the patient profile where in a new onset you would prefer using a glimepiride metformin or a gliclazide metformin combination, still given the fact that 25% of the market share of combination antidiabetic is held by glimepiride metformin till date?
Yes, absolutely. A very practical question. With availability of cheaper alternatives to sulfonylureas, particularly the SGLT2 inhibitors and DP4 inhibitors, of course, we have a wider choice. Now, if we talk about the first line, in addition to metformin, maybe a kind of second line also, I think one of the areas where it can be used when the patient is a bit symptomatic, not very much symptomatic to begin with. There are some symptoms of hypoglycemia and you want to control blood glucose level pretty quickly. Now, other than insulin, there is no other agent that can reduce blood glucose levels so rapidly in type 2 diabetes. So in that particular situation, it can be used. Number 2, SGLT2 inhibitors is a kind of excellent kind of benefits, and it is also very efficacious drug. But the problem is that there are some patients where there would be contraindications and where we should use it very cautiously. So in those patient population, of course, we may use it. And again, a very practical point, many of our type 2 diabetes patients are on 3 drugs, on triple drug therapy. And some of them may be even on 4 drugs, as I've said. So in those situations, sulfonylurea still has a very important role to play. So I think practically these are the three areas where we may still continue using sulfonylurea.
Before I go on to the next speaker, he talked about at the beginning. So would you not consider someone in the higher tertiles of HbA1c who was presented with perhaps an 8.59 and is unwilling to start with insulin, not really that much of osmotic symptoms?
Yes. Not really osmotic. I mean, patients with severe osmotic symptoms, there is no question.
No choice.
You must start with insulin. Yeah.
And insulin.
But in some of those patients, even as NICE guidelines actually pointed out, and practically I also in favor of in some of my patients, that initially, if we feel it's a type 2 diabetes and patient very much symptomatic, sometimes I start with metformin along with sulfonylureas plus basal insulin. So I tend to take off basal insulin after maybe one or 1.5 months or so, and then we can modify our therapy. So this is another kind of use of this drug at the initial period, which I use. And in long run, of course, you can use along with basal insulin, as I said.
Thank you, Dr. Bhattacharya. Thank you so much for being with us and spending your time and highlighting on a nearly forgotten, not really forgotten, but going into oblivion sort of sulfonylurea from the dual pressure of newer drugs and being available at a lower price. Thank you so much. And before we go on to the next session, thank you and have a nice weekend. I can see Nilanjan is waiting. Just after a small video, we would go on to Professor Dr. Nilanjan Sengupta, who is the current head of the Department of Endocrinology of NRS Medical College, with many an accolade under his belt. I would introduce him to you just after a small video.
Hello friends, this is Dr. Chaudhuri, and I'm really happy to note that the ENDIAB Summit is back again, like the last few years, to commemorate the Charles Best Memorial Day. And this year's program looks really good. Hope that we can all get together again for a wonderful academic extravaganza. Hello friends.
Thank you. Thank you so very much. Now the topic for Professor Sengupta is evidence-based optimization of EMPA+Lina fixed dose combination in patients of type 2 diabetes mellitus, and who can do more justice to this than Professor Nilanjan Sengupta. Over to Dr. Sengupta, who is Professor and Head Department of Endocrinology, Honorary General Secretary, Endocrine Society of Bengal, and Associate Editor to Indian Journal of Endocrinology and Metabolism. He is a Governing Council member to the RSSDI West Bengal Chapter, Secretary, Board of Studies in Endocrinology, West Bengal University of Health Sciences, Coordinator, DDCT course, State Medical Faculty of Bengal, and more than 80 publications in national and international journals. Over to you, Nilanjan, for the needful.
Thanks for your kind introduction, Soumyabrata, and it's always a pleasure to be in the ENDIAB Summit. Please allow me to share my screen.
Yeah, you can.
Yeah. Let me try. Hope it is visible.
Yes, sir.
So after the brilliant exposition by Dr. Rana Bhattacharya, I will be definitely talking about EMPA+Lina combination, fixed dose combination, and I don't want to actually compress sulfonylureas in the hydraulic press of EMPA and Lina working from either side. I do acknowledge that sulfonylureas are there to stay in the market for the benefit of our patients. Having said that, let's look at the utility of this EMPA+Lina combination. As has been pointed out by Rana, uncontrolled glycated hemoglobin is a major concern globally. No matter what agents we use, how good insulins we have, how novel oral anti-diabetic agents we employ, there would be some patients who would be difficult to treat, who would struggle to achieve the glycated hemoglobin. And if you look on a broader perspective, from the individualistic to the global perspective, about 30% of patients globally of diabetes have a glycated hemoglobin beyond 9%, which is absolutely unacceptable. And only about 13% patients in this part of the world can achieve the desired glycated hemoglobin of 7. Now, this is the standard step care approach in the management of type 2 diabetes, starting with therapeutic lifestyle change alone, then adding metformin, probably adding a sulfonylurea, then adding a thiazolidinedione, and now probably a DPP-4 inhibitor, and then go on to insulin. Now, while acknowledging the utility of this step care approach, today we have become more aggressive, and we tend to start with combination therapy right from the very beginning in the life of type 2 diabetes. Why do we do this? We do because of 2 reasons. One, because of the understanding of legacy effect of glycemic memory. That is, if you can control hyperglycemia from the very beginning and can maintain it, then the patient reaps ultimate benefits in the long run. Second, we have now excellent agents in DPP-4 inhibitors, incretin analogs, SGLT2 inhibitors, not to forget about metformin, and even the now discarded thiazolidinediones, which can control hyperglycemia without causing hypoglycemia. So, in one word, availability of safer anti-diabetic agents have emboldened us to go for combination therapy in a much more aggressive way, thereby achieving and maintaining glycemic targets of 6.5 or 7 much easier. So we all know what are the factors for disease progression so far as type 2 diabetes is concerned, not only the glycated hemoglobin, but a BMI, which is unfavorable, a lipid profile that is atherogenic and unfavorable, and also the duration of diabetes. And of course, HbA1c at diagnosis and thereafter would be one of the main determinants of disease progression. Now, let's have an illustrative case. This 50-year-old gentleman has been suffering from diabetes, hypertension, and dyslipidemias in the last 2 years. BMI is on the higher side, is on metformin, but he is uncontrolled on metformin. Now, what to do in this case? So this is a very real-life scenario with metformin monotherapy. The patient is having a glycated hemoglobin of 8.6. Both the fasting and PP are high, and the PP is quite considerably high at hovering around 280 milligram per deciliter. Renal function is not that bad. So what to do? So we all agree that we have to bring down the glycated hemoglobin in this patient. I would love to bring it under 6.5 from 8.6. That is almost 2 percentage point glycated hemoglobin down. And you can well understand a single agent alone probably is not going to do that. The common understanding is we need to give 2 agents on top of metformin to achieve our glycemic target of 6.5, at least 7. So the moot question is that, should we give a single agent, say a DPP-4 inhibitor, wait for 2 to 3 months, and then add an SGLT2 inhibitor, because these are the ones which we would be using rather than sulfonylurea. In my practice, as Rana has said, I keep sulfonylurea maybe as the third or the fourth agent to add on in the treatment paradigm, unless there are other compelling circumstances. So the moot question is that at this point of time, in a 50-year-old male who is having uncontrolled glycemia, A1C 8.6, who is obese with an additional risk factor of hypertension, do we give sequentially a DPP4 inhibitor like linagliptin or sitagliptin and then add an SGLT2 inhibitor, or do the other way around, start with an SGLT2 inhibitor and add a DPP4 inhibitor, or straight away give the two at one go? So there are certain August body recommendations of initiation with a combination therapy. Actually, the AACE ACE 2020 guidelines, or even before that, actually ask us to go for dual or triple therapy at initiation. If the glycated hemoglobin exceeds 7.5%, you go for dual, and if it's hovering towards 8.5 and 9, better to start with a triple drug, and if about 9, definitely a triple drug or with insulin. So there are recommendations. Now we come to the DPP4 sulfonylurea, DPP4 SGLT2 combination, because this is my brief this evening. You have already heard about sulfonylureas. Now, if you add a DPP4 SGLT2 inhibitor like an EMPA+Lina combination, apart from glycemic control, you tend to get certain other pleiotropic benefits. Like this combination may be weight neutral or even effect weight loss, then it can also afford cardiorenal benefits. So if you go for the holistic metabolic management, not coming out from the glucocentric attitudes, then I think this combination suits well. And this, you know, is the ominous octet. And if you use this combination, it will actually target many of the defects that we encountered in diabetes, that is type 2 diabetes, that is defects in the enteroinsular axis, defect in the beta cell, defect of hyperglucagonemia, and so on and so forth. Even to some extent, neurotransmitter dysfunction, and of course, metformin is already there, which can take care of the insulin resistance. So, as I said, this patient, of the three options, sequential use of DPP4 inhibitor, SGLT2 inhibitor in that order, or the reverse order, or a combination of a DPP4 inhibitor and SGLT2 inhibitor, a little bit aggressive therapy. At this point of time, I would rather go for an aggressive therapy. Now, whether you use a fixed dose combination of empagliflozin and linagliptin, or dapagliflozin and saxagliptin, that is up to you. You can use a fixed dose combination, and you can use them separately also. But then if you have a fixed dose combination, you can decrease the pill burden and many a time also the cost of therapy. So I think that is a rational combination. And coming to the science behind it, apart from affording aggressive glycemic control, but without causing hypoglycemia or other major side effects, there is also a complementary efficacy. Simply because if you are using an SGLT2 inhibitor, there is tendency to loss of energy by way of glycosuria. And when there is loss of energy, the body will try to, as a compensatory mechanism, go for increased hepatic glucose output to counteract that energy loss. And that can be taken care of by an incretin-based therapy like a DPP-4 inhibitor such as linagliptin, so that this compensatory tendency towards increased hepatic gluconeogenesis can be taken care, that is seen with SGLT2 inhibition can be counteracted if you are using a DPP-4 inhibitor in the same time. And we know with SGLT2 inhibition, there may be slight increased incidences of genital mycotic infections because of glycosuria. But there have been studies by Boehringer Ingelheim which tries to suggest that if DPP-4 inhibitor and SGLT2 inhibitor are co-prescribed, the chances of genital mycotic infections may be less, because probably it has been hypothesized that DPP-4 inhibitors also tend to inhibit the DPP-4 enzyme in the fungi. So apart from a more robust glycated hemoglobin reduction, we can have some benefits so far as side effects are concerned. So body weight reduction you can expect in these patients, because a DPP-4 inhibitor is weight neutral, whereas with an SGLT2 inhibitor, you can get about 3 to 4 kilos weight loss. So effectively, this EMPA+Lina combination can cause some weight loss, and this patient was having a glycated, a BMI hovering around 29, 28 and a half, 29. So if the BMI can be brought down to under 27, like 25 or 26, that would be excellent. There may be an option for BP reduction because of the diuretic and natriuretic properties of the SGLT2 inhibitor and overall cardioprotection. So as we all know, hypoglycemia with these agents is minimal. Neither the DPP-4 inhibitors nor the SGLT2 inhibitors cause hypoglycemia on their own, and that is an advantage. And that is specifically the reason why we can afford to be aggressive at this point of time, which we probably wouldn't have been able to do with a sulfonylurea-based combination. The specter of hypoglycemia always looms large. So in this reference case, we can expect early and robust glycated hemoglobin reduction, a good weight and BP control, and with minimal hazard. That is the advantage. So that is it. Again, I told you, we have to look beyond glycemic control these days. I won't bore you with the details of the cardiovascular outcome trials that we have seen with empagliflozin, the very famous EMPA+REG outcome, which actually decreased cardiovascular death. And we have other studies like Carmelina with linagliptin, which has also attested its cardiovascular safety. And suffice it to say, combining the two will give the patient benefits of the two. What are the benefits of linagliptin apart from glycemic control? Renal safety, cardiovascular safety, ease of use, and so far as empagliflozin is concerned, the renoprotective properties, the cardio CV protective properties, decrease in body weight and intra-abdominal adiposity, which can indirectly improve insulin sensitivity. That is also a very important thing. This patient is overweight, having diabetes for a long time. Maybe this patient was also suffering from some degrees of non-alcoholic fatty liver disease that also can be taken care of by the SGLT2 inhibitor. So this is really a good combination. So as you all know, I think this is like bringing coal to Newcastle. You have been using fixed dose combination is available in 2 different once daily dosages. I need not go into the details of it, and they can be given any time of the day, irrespective of about the last meal, and risk of heart failure. Again, you know, SGLT2 inhibitors are now being recommended for the management of heart failure, even without diabetes. So that is an important thing. So these drugs have good evidences behind them. Unlike you can say, okay, this is a slightly more costly combination. Why can't we think of a remogliflozin-vildagliptin combination? Because that is also a combination of an SGLT2 inhibitor with DPP4 inhibitor, but mind it, vildagliptin does not have any dedicated cardiovascular outcome trial, and there have been some concerns with diastolic dysfunction or even increase in the end-diastolic volume in the VV trial, and remogliflozin doesn't also have any cardiovascular outcome data worth its name. So if you have to use an SGLT2 DPP4 inhibitor combination for both glycemic and extraglycemic benefits, you should choose 2 molecules which have data and evidence behind them. Just not just look at the cost of therapy, because as I said, this Vilda remogliflozin combination doesn't have evidence. So I think we can skip this slide. Again, if I have to choose DPP4 inhibitor, my choice would be sitagliptin or linagliptin rather than saxagliptin or vildagliptin if we consider the heart, or even allogliptin, because there are certain disturbing signals so far as heart is concerned. And if I have to select an SGLT2 inhibitor for both cardiovascular, cardiorenal, and glycemic benefits, it has to be empagliflozin, dapagliflozin, or even canagliflozin, but not definitely remogliflozin, which do not have data on the pleiotropic benefits. So I think not only for the treatment of hyperglycemia of diabetes, but for holistic metabolic control, this is an important fixed dose combination, important, rational, cost-effective, and medically effective combination, which can be in a patient like this. And this is the cost, I think. If the patient asks you, why are you giving a costly pill like this? Then you can explain to the patient that if you treat diabetes well for years from the beginning of your diabetic life, ultimately you have to spend less on hospitalization, spend less on doctor visits, spend less on laser photocoagulation, intravitreal pharmacotherapy, repeated dialysis sessions, transplantations, CABG, so on and so forth. So I think in this patient, in this illustrative case, I have shown the importance of not only early initiation of therapy, but early intensification, and early intensification with a combination of empagliflozin and linagliptin, that is a DPP4 SGLT2 inhibitor combination. So with this, I thank you for your patient hearing, and I again thank the organizers for inviting me as every year for their ENDIAB Summit on Charles Best Memorial Day, and making me a proud part of it. I was listening to the quiz, which also I thank Soumyabrata for taking this great step of honoring this quiz in the name of late Santosh Rastogi. The quiz was a very interesting one. I learned many things from the quiz itself, And this is actually a picture of Charles Best with his compatriot Clark Nobel, who actually lost the toss of the coin to assist Banting. That's why he has not been that famous, but he also went on to become a good scientist, and he was been credited to discovering wind blasting. So I think that we tend to forget. So I took this opportunity to tell you this little anecdote, and I thank you. And if there are any questions, I'll be glad to take them.
Thank you, Nilanjan, ebullient as always, and I'll come back to you after the promotional video. Thank you, Nilanjan. Thank you for that wonderful talk. There are two egging questions out here. One delegate has asked, considering this to be a scientific forum, if we keep economics out of our baggage, how would you consider the peptide in a pill in your case? Would you consider? Would you not consider, and why?
Yeah. Definitely, I would consider peptide in a pill in lieu of the DPP-4 inhibitor if we want a greater glycemic control. But how can I ignore the economics? Because pharmacoeconomics is a good thing. In this patient, if the job is well done with a DPP-4 inhibitor and an SGLT2 inhibitor combination, maybe separately or in a fixed dose, that's your choice. I may not consider a peptide in a pill. But yes, if I put this patient on this regimen, after 6 months, I find the glycated hemoglobin is 7.2 or 7.3, then I can think of persisting with the SGLT2 inhibitor and replacing the linagliptin with semaglutide or ribelsus as it is available if the patient's pocket permits, and if there are no other contraindications. There are actually not much contraindications. If you can use linagliptin, for that matter, you can also would be able to use semaglutide. But I think I would give, in this patient, in this illustrative case, I would first try to give linagliptin a choice, a chance. If linagliptin fails, then I think semaglutide is always there.
Now there's a second one coming up for you. Keeping economics in mind, and keeping in mind that we are possibly going to have a CETA and a DAPA combination in times to come, and both in generic form, what would be your choice? Would you choose that?
Yeah, conceptually, a CETA-DAPA combination, so far as pleiotropic benefits is concerned, upfront, prima facie, would be much better than a Remo-Wilder combination, so far as cardiovascular and renal disease is concerned. But then one argument you have to keep in mind, Professor Chowdhury is there. He actually asked me this question in another forum. But if you are talking of that, the data that has been generated are with the innovators, not probably with the bioequivalent molecules. Can you really extrapolate the data? So this question is difficult to answer, because whatever data you have with innovator dapagliflozin and innovator sitagliptin, whether that can be extrapolated, but well, if the cost of therapy is not an issue, I would still go by the innovator brands. But if cost of therapy is an issue, I would rather give the benefit of doubt to a CETA-DAPA combination than a Wilder-Remo combination for the glycemic as well as extraglycemic neotropic benefits.
So at the end of it, the proof of the pudding will be in the eating, I suppose.
Right, but how can you really prove? Because for cardiovascular endpoints, you have to wait for 10, 20 years. For the glycemic thing, the proof comes early. That's also an issue.
Thank you, Nilanjan. That was a very, very enlightening case discussion. And we also have, we had two futuristic questions for you, and you have answered both of them in a very, very scientifically valid way. And I think it would give our delegates a lot of learning points in their practice. Thank you so very much for being with us every year, and we would love to have you the next year, but in person.
I think I would love to attend physically, the COVID situation permitting. Thank you.
Thank you so very much. And after a small amount of, perhaps I would go in for Dr. Mainak Banerjee. The relevance of diabetes management safety. This is our next speaker, Dr. Mainak Banerjee, who is a consultant endocrinologist at the Rabindranath Tagore International Institute of Cardiac Sciences. And Dr. Mainak Banerjee is a DM in endocrinology and has got numerous publications in national and international journals. And over to you, Dr. Mainak, please, for your presentation. Dr. Mainak, please go into full screen mode. Yeah, you're full screen. Unmute yourself if you're on mute.
Am I audible now?
Yes, yes, you're audible.
Okay, okay,
Please,
fine.
the stage is all
Thank you, sir, for your kind introduction. And at the outset, I would like to thank the organizers for making me part of this panel of eminent speakers. So without wasting much time, I would go straight to my topic, that is the relevance of diabetes management safely. Now, why is it relevant to manage diabetes safely? We know that the diabetes is associated with several underlying conditions, comorbidities such as cardiovascular disease, renal impairment, hepatic impairment, obesity. Now, some of these comorbidities can pose a hypoglycemia risk, but at the same time, you have to have an effective glycemic control to prevent the complications of diabetes. And we know that hypoglycemia, which is a dreaded complication of diabetes, it is associated with greater likelihood of treatment discontinuation, and which can lead to further economic burden. And recurrent hypoglycemia has also been associated with cognitive deficit in elderly, and it can also lead to repeated clinic visits leading to higher cost, and overall there will be a deterioration of quality of life in patients. So the agenda of my talk would be that why correct diabetes classification is important to prevent complications and take safe treatment decisions, how to initiate VAD safely in type 2 diabetes, what are the issues in elderly, and how to manage diabetes in case of CKD and CLD, and last but not the least, how to manage hypoglycemia and how to adopt preventive strategies for hypoglycemia. So the first case, my first case, Ms. Shuniti, 42-year-old woman, has come with uncontrolled diabetes, fasting 382, PP 467, HbA1c 8.3%. Diabetes was detected 2 weeks back. She complains of severe osmotic symptoms, burning sensation during micturition, and she was started on glimepiride 1 mg and metformin 1000 mg by primary care physicians. Her BMI is 22.3 kg per meter squared. There is no family history of diabetes. There are no features of insulin resistance. And at the present moment, there is no dehydration. Tongue is moist, respiratory rate is regular, and she is able to take feed orally. And urine ketones was done, and it was nil. And the patient was started on basal bolus insulin in view of this clinical scenario. And later on, it was C-peptide reserve testing was planned, and post-mix meal 90-minute C-peptide reserve testing showed that there is a significant decline in the C-peptide reserve. That's suggestive of type 1 diabetes. So what is the take home? What are the take home messages from this case? We have to educate our fellow primary care physicians that not all cases of type 1 diabetes have young onset and ketosis at diagnosis. And we, at the same time, we have to watch out for the latent autoimmune diabetes in adults. We have to screen for ketoacidosis when in doubt for appropriate decay protocol from the very beginning. And obviously for stamping the diagnosis of type 1 diabetes, you have to have a C-peptide reserve testing after achieving euglycemia, and also you need insulin autoantibodies for confirming. But if you have a C-peptide reserve testing that is the low C-peptide, then you can say it is a type 1 diabetes in this current scenario. So the basal bolus insulin is mainly the gold standard in type 1 diabetes, and that has to be instituted from early on. And metformin can be considered if there is coexistent insulin resistance. And another thing that is very important, that we have to watch out for hypoglycemia in the honeymoon phase of type 1 diabetes when the insulin requirement decreases. So these are the take-home messages from this case, and we have to keep that in mind. Now, coming to my second case, Mr. Bishwas, a 25-year-old man, has come with suboptimal control of diabetes detected 1 year back. Fasting is now 172, postprandial is 313. He was on therapy of glimepiride 2 metformin 1,500 milligram once daily, along with teneligliptin 20 milligram. He has, again, no family history, no features of insulin resistance, and no abdominal imaging was also done. So now one abdominal imaging was ordered, and now the straight section abdomen reveals that there is radiodense particles along the pancreas. So the diagnosis was made that it is a case of fibrocalcious pancreatic diabetes. Now, when we talk about FCBT, we generally picturize a lean young adult with triad of abdominal pain, steatorrhea, diabetes, generally belonging to lower socioeconomic stratum. But there are certain points that we have to keep in mind, that the facts are that pain may not be a significant symptom in them, steatorrhea may not be there, and the presenting feature may be only diabetes. And FCBT has also been found in individuals belonging to more affluent classes. So all these things we have to keep in mind. So, correct diagnosis of diabetes can help us to take safe decisions from the very beginning. In this case, teneligliptin was ordered, but we know that it is generally better to avoid DPP-4 inhibitor in pancreatogenic diabetes due to future risk of pancreatogenic carcinoma. And the therapy required mostly insulin. So the patient was started on insulin premix and 1 voglibose metformin combination before lunch, and we were able to achieve glycemic control in that patient. Now, coming to the case 3, we often see that it is now the case 3 is Mr. Bishwas, that 35-year-old man who has sought a second opinion after being diagnosed with new onset type 2 diabetes. And at that time, his fasting was 180, postprandial was 221, but he was started on oral hypoglycemics like glimepiride 1 milligram and metformin 500 milligram combination. And now he is complaining of dizziness, fasting blood sugar 67, postprandial 81. Now it is clearly seen that there was no need for sulfonylurea therapy as first-line agent in this patient. Now, so the glimepiride metformin combination was stopped. Patient was shifted to metformin 500 milligram once daily. This is also something that we see day to day. Someone has started in new onset diabetes. Someone has started sulfonylurea therapy, but it should not be done. So patient was only shifted to metformin 500 milligram once daily, and after 1 month his fasting blood glucose was 102, postprandial was 143. So the approach always should be to use the start low and go slow principle in initiating and increasing medication, to adhere to the guidelines and monitor response after each titration. Now, there is one important aspect that I would like to highlight, is that if metformin can cause often GI intolerance. So if if we find that with high doses there is GI intolerance, sometimes it is better to try the sustained release form and to go very slow with 500 milligram daily, once daily dose, and then gradually build up. But still, if the patient complains of GI intolerance, it's better to start with DPP-4 inhibitors or low-dose sulfonylureas. Now, coming to the choice of second line, if you take these important points in mind, like obesity, CKD, duration of diabetes, established CVT. So if a person who has all these factors, probably SGLT2 comes first line. Regarding the GLP-1 agonist, if the patient is obese and established CVD, it becomes second line just because of the cost, because we have to take in account the economic issues of the patient also. And coming to the DPP-4 inhibitors, it is clearly noted that DPP-4 inhibitors is a very attractive second line agent when it comes to treat diabetes in elderly. And if you coming to the sulfonylureas and insulin, if the diabetes duration is very long and you need to have a quick control, probably sulfonylurea is the better choice. And if the patient has any underlying infection, it's better to go for insulin therapy for quick control of diabetes. So these are the choice of second line agents we have to keep in mind. And coming to the next topic, that is the diabetes in elderly. What are the issues of diabetes in elderly? We know that the type 2 diabetes is an age-related disease with a prevalence of 33% in US population, ages 65 years or older, and nearly 50% of older people meet the criteria of prediabetes in US population. Now, the diabetic in elderly has a distinct pathophysiology because elderly patients often have increased adiposity, decreased muscle mass, and also because of the sedentary lifestyle, they have this high risk of diabetes, and some of them may have a decreased response to incretin also. And apart from this, there are also safety concerns related to hypoglycemia in elderly. Elderly patients may have impaired counter-regulatory adrenergic response to hypoglycemia, and so they may have impaired glucagon reserve as well. So all these factors taken together emphasize the need for special attention to treat diabetes in elderly. So coming to the management strategies, what should be the treatment goals in elderly diabetic? So if the patient is healthy, a reasonable A1C goal of 7 to 7.5% or maybe less than 7% may be targeted without any risk of hypoglycemia. Now, if the patients have multiple comorbidities, patient is frail, then it is reasonable to have a relaxed HbA1c target that is 8%. And if the patient has some end-stage chronic illnesses like end-stage chronic kidney disease, and there is a risk of severe hypoglycemia, there is history of recurrent hypoglycemia, then sometimes A1C may be relaxed up to 8.5%. And in those cases, blood pressure target should also be relaxed, like 150/90. And coming to the statin treatment, we have to consider likelihood of benefit of statin in those patients, like if the patients have end-stage kidney disease, then if the patient is not on statin, probably statin should not be initiated because there is very minimal risk of mortality benefit, minimal or mortality benefit with statins in those patients. So coming to the management strategies in elderly, we as clinicians have to screen them for mild cognitive dysfunction to determine if those patients are able to perform self-care tasks and if they are able to monitor and respond to hypoglycemia. We should also perform functional testing like hearing, vision loss, frailty assessment to determine whether patients are physically able to respond appropriately to hypoglycemia. And coming to the dietary adherence, it has been shown in studies that approximately 40% of older adults do not meet the recommended 0.8 gram per kg protein intake. So for them, we need to have a dietary guideline. We have to educate them. We have to educate their caregivers so that they can adhere to this recommended protein intake. And last but not the least, we have to identify caregivers we have to educate them, and we have to simplify the treatment regimen so that they can adhere to that simplified treatment regimen. And coming to the hypoglycemia risks, as I have already said, that those patients may not have some adrenergic response to hypoglycemia. They may not show those autonomic symptoms like in elderly diabetic, like in young diabetics. So we should not rely upon signs and symptoms of hypoglycemia, which may be absent in this population. So coming to the choice of agents in elderly, coming to the sulfonylureas, they are very notorious for hypoglycemia. So we have to watch out for hypoglycemia. Now coming to the another agents like SGLT2 inhibitors, they can offer good glycemic control. They can cause reduction in the severities, but when it comes to the tolerability profile, they may cause increased urinary tract infection, genital mycotic infection, and particularly elderly frail individuals may be more prone to hypovolemia, dehydration, and postural hypotension. So in those patients, SGLT2 inhibitors should be avoided. So for those patients, as a second line agent, DPP4 inhibitors is a very efficacious, safe agent with minimal tolerability issue. And particularly if we consider linagliptin, once daily dosing with no risk of hypoglycemia and no need for dose adjustment in chronic kidney disease makes linagliptin an attractive second line agent for use in elderly. Now, if we need insulin for intensification, then probably basal insulin analog should be preferred. However, even in those cases, we have to watch out for hypoglycemia, and glitazones generally are glitazone use is generally restricted because of the weight gain, fluid reduction side effects, and of course osteoporosis in postmenopausal women. So coming to the managing diabetes in CKD, what should be the glycemic targets? The ideal target range is around 7%. However, it should be relaxed if there is a history of severe hypoglycemia, limited life expectancy. Self-monitoring of blood glucose should be advised. And we have to keep in mind certain facts about HbA1c, because carbohydrate hemoglobin, iron deficiency, metabolic acidosis may cause falsely elevated HbA1c. So we should not, we should be very cautious while targeting HbA1c. For those patients, we have to rely more on the self-monitoring of blood glucose and fasting and postprandial blood glucose. And now coming to the management part, insulin regimens commonly used, particularly when the weight is failed and easy to adjust, and there is no specific contraindication of insulin regimen type, and we have to avoid hypoglycemia with individualized doses. So any insulin regimen can be used only provided that there is no hypoglycemia. And however, if there is a high risk of fasting hypoglycemia, it is better to avoid basal insulin. In some patients with advanced CKD, we often find that the prandial rapid-acting insulin sufficient for optimum glycemic management due to increased half-life of insulin in them. And self-monitoring of blood glucose, as I have already told, it should be done accordingly. So coming to the agents, we all know that metformin, we have to reduce the dose if the eGFR is 30 to 45. And we can cautiously use in eGFR 45 to 60 group. And however, we have to stop metformin if eGFR goes below 30. With pioglitazone, generally there is limited use due to fluid retention, anemia, and risk of osteoporosis. Repaglinide can be used in CKD stage 1 to 3. Glucosidase inhibitors are generally contraindicated in renal failure. Now coming to the sulfonylureas, limepiride can be used if the eGFR is more than 30. However, it should be cautiously used because it can cause hypoglycemia. And when comparing limepiride with gliclazide, probably gliclazide has a lower hypoglycemia risk. And gliclazide, however, it is better to avoid gliclazide if the eGFR goes below 30. And coming to the glipizide, generally no dose adjustment is needed. However, still it can cause risk of hypoglycemia, so it is better to avoid if eGFR goes down below 30. So the experience with glycoside, as I have already told, there were in guide study, there were significantly lower rates of confirmed hypoglycemia with glycoside as compared to glimepiride. And probably it is because of the fact that glycoside is the only sulfonylurea reported not to bind to EPAC2, which is a stimulating factor for insulin exercises and release. Now, coming to the management with DPP4 inhibitors part, we can clearly see that sitagliptin, vildagliptin, all these gliptins require dose adjustment when EGFR goes below 60. But in case of linagliptin, in moderate and severe renal infarction, linagliptin it does not require any dose adjustment. So it is because of the fact that the linagliptin is generally minimally metabolized and it has a primarily biliary excretion, whereas coming to sitagliptin, it is minimally metabolized, but it has primary renal excretion. So this explains why linagliptin does not require any dose adjustment in chronic kidney disease. Now, if we look at the glycemic efficacy of linagliptin, which is important to note that it can lower HbA1c effectively in patients with different stages of renal impairment. So in the EGFR less than 30 and in 30 to 50 group, it has clearly been shown that linagliptin therapy can improve HbA1c. And coming to the hypoglycemia risks, obviously I have already told that linagliptin is associated with minimal risk of hypoglycemia. So in these studies as well, that it has been shown that linagliptin provided clinically minimal improvement in glycemic control with very low risk of severe hypoglycemia. And another important study that I would like to mention, if the patient is on insulin along with linagliptin, linagliptin can also permit the reduction of insulin dose in patients with severe renal impairment over 52 weeks. And coming to the renal outcomes of linagliptin, the MAR-LINA outcome trial, it clearly showed that linagliptin might have some renoprotective effect because the surrogate endpoints of albuminuria progression was decreased with linagliptin therapy in MAR-LINA renal outcomes trial. However, the mean EGFR did not change. Now, the albumin lowering by linagliptin was found to be independent of improvement in glucose in this study, which is a very important point to note. So coming to one post-hoc analysis of MAR-LINA T2D trial, they showed that participants treated with linagliptin were 70% more likely to achieve a meaningful response, more than 20% decrease in urine ACR at week 24 relative to baseline, than to show no response. So clearly there was a renoprotective effect. So what are the proposed renoprotective mechanisms from all these studies? The proposed renoprotective mechanisms are that they may have an antioxidant effect, and in some cases it was found that DPP4X may be overexpressed in patients with diabetic nephropathy. So DPP4 inhibition may improve the mitochondrial dysfunction and improve overall endothelial dysfunction, leading to the neuroprotection and microalbuminuria reduction. So if we look at the renal outcomes with Carmelina, although the EGFR, although the exploratory kidney outcome like the sustained ESRD, death due to kidney failure, and sustained decrease of more than 50% in EGFR from baseline, this particular outcome was not decreased with linagliptin compared to placebo, but albuminuria progression was significantly decreased with linagliptin therapy. And we know that albuminuria is a cardiovascular risk factor. So if we can halt the albuminuria progression, so linagliptin might have some long-term impact in terms of cardiovascular risk reduction. However, coming to the SGLT2 inhibitors, now SGLT2 inhibitors, if we look at the renoprotection potential of SGLT2 inhibitors, they clearly show that if we look at the DAPA-CKD Credence trial, they clearly show that there is a significant benefit with EGFR decline as well. And also there are significant benefits on hospitalization due to heart failure in patients with CKD. So with the advent of SGLT2 inhibitors, where do DPP4 inhibitors stand? We have already shown that the studies on DPP4 inhibitors mostly demonstrate safety rather than true efficacy in contrast to SGLT2 inhibitors. And studies on DPP-4 inhibitors indeed showed improvement in surrogate endpoints such as microalbuminuria, and this microalbuminuria reduction may have some long-term meaningful effect in terms of cardiovascular risk reduction. However, it has to be kept in mind that SGLT2 inhibitors have some tolerability issues, particularly in elderly individuals. So DPP-4 inhibitors have the edge over SGLT2 inhibitors, particularly in those patients, and they are safe to use at any stage of CKD, and they have beneficial effects of glucose control without inducing hypoglycemia or risk of postural hypotension or dehydration in elderly individuals. And last but not the least, it has to be kept in mind that adding DPP-4 inhibitor to SGLT2 inhibitor was associated with lower incidence of urinary tract infections in few studies. So this combination may also be helpful. So if you have some patient who is already on SGLT2 inhibitors, linagliptin, addition of linagliptin or DPP-4 inhibitor may help. So coming to the this case for 60-year-old female attendant who has a history of recurrent UTI, who is on atorvastatin 40, levothyroxine 50, aspirin 75 milligram, metformin 1 gram. Her BMI is 30, A1C is 8.4%, fasting is 148, postprandial is 230, and EGFR is 37.6. Now, ECG shows is evidence of old inferior wall myocardial infarction. So, which anti-diabetic agent to add as second line to metformin in this patient? Now, if we look, if we take the holistic approach, first question should be that what should be his glycemic target? Like this patient was 60 years old, diabetes duration was 7 years, and the patient had CKD, old inferior wall myocardial infarction was there. So very intensive control may not be required, and hypoglycemia history also has to be kept in mind. And so choosing one second line agent has to have an holistic approach. We have to keep in mind the risk of hypoglycemia and CKD, risk of weight gain since the patient has already a BMI of 30. And we also need to have some OAD which can offer renal protection and CV safety. However, we also have to consider potential side effects of oral anti-diabetic agents. So in this case, basically linagliptin was added, SGLT2 inhibitors was not added in view of history of recurrent urinary tract infection. And you can clearly see that with addition of linagliptin after 1 month, glycemic status was optimal. Now coming to the next important topic, how to manage diabetes.
You have a couple of minutes to wind up, please.
Okay, sir. So insulin regimens often used in decompensated cirrhosis, and we have to watch out for hypoglycemia. Metformin has been safely used with survival benefits. However, we have to avoid in case of alcoholism and coexistent renal dysfunction. Pioglitazone has been used in NASH, but it is better to avoid in childhood BC cirrhosis. However, it is important to note that pioglitazone did not show any benefits on disease progression in NASH. And coming to the SGLT2 inhibitors, they may be used cautiously for childhood A-B cirrhosis without dose adjustment. However, in patients who have coexistent renal dysfunction, probably it is better to avoid those agents because of a risk of hepatorenal syndrome. Now, coming to the DPP-4 inhibitors, they may offer a safe, effective therapy in CLD. In fact, mild, moderate, and severe hepatic impairment did not result in increase in linagliptin exposure after single and multiple dosing compared with normal hepatic function. Now, coming to the last case, I have 5 or 6 slides. Now, this 78-year-old man came with nausea, generalized weakness. The patient was on MSI along with metformin and dapagliflozin 10 milligram. Now, self-monitoring of blood glucose revealed frequent hypoglycemia, and however, the patient informed us that he had no adrenergic symptoms during these hypoglycemic episodes. Now, the patient was admitted in view of dehydration, and the pH has came out to 7.2, and a diagnosis of euglycemic decay was made. Now, coming to the concerns with SGLT2 inhibitor for this patient, the patient was 78 years old. The patient was on MSI, and the patient had a history of unhealed diabetic foot ulcer. So keeping all these things in mind, that it is better to discontinue if there is any signs of active infection in an elderly patient because of this catabolic state and risk of ketosis. And importantly, it is better to avoid SGLT2 inhibitors in elderly long-standing type 2 diabetes because of risk of euglycemic decay if you have insulin deficiency state. And very old patients are often prone to risk of dehydration and postural hypotension, and that may increase falls and long bone fractures, leading to increased mortality. So for those patients, SGLT2 inhibitors should be avoided, and like in this case, SGLT2 inhibitor probably led to euglycemic decay for this patient. And another important factor in this patient was hypoglycemia unawareness, and that's why we recommended a reduction in both his insulin glargine and aspart, and we emphasize the risk of relative safety of 3 weeks of mild hyperglycemia to restore autonomic symptoms in this patient. So coming to the hypoglycemia, I'm not going into the details of treatment of hypoglycemia. We all know that. Now coming to the strategies to prevent, if there is one episode, we have to adjust the sulfonylurea and insulin dose, probably avoid repaglinide also, and we have to consider alternate treatment with minimal risk of hypoglycemia. We have to remind patient to carry enough carbohydrate with them. We have to advise them to perform SMBG and wait for euglycemia before engaging in activities like exercise and driving, childcare, etc. And coming to the hypoglycemia unawareness, which may lead to severe hypoglycemia and increased mortality, we have to strictly avoid hypoglycemia for at least 2 to 3 weeks. And for some patients with brittle diabetes, for many patients with brittle diabetes, CGM is an effective tool. Now, coming to other strategies to prevent unplanned meal, alcohol ingestion, using multiple medication like polypharmacy and associated comorbidities has to be kept in mind. Particularly for type 1 diabetes patients, if the patient plans an exercise, we have to reduce the rapid acting insulin bolus dose before exercise, and we have to advise SMBG before and after exercise to avoid hypoglycemia in those patients. And there are several medications which may lead to hypoglycemia, like warfarin, salicylates, some beta blockers, and allopurinol. So those agents, if the patient are already on those agents, we have to keep that in mind. So last but not the least, we have to follow a structured patient education program for improvement in active patient involvement. We have to establish, maintain communication with the patient. We have to educate the patient for self-management of the condition, and we have to inform the patient on treatment plan, diet modification. So that's how we can manage the diabetes safely. So to conclude, correct diagnosis of diabetes type is important for safe decisions from the very beginning. For type 2 diabetes management, you have to start low and go slow. In the same time, we have to avoid insulin inertia when there is a need for intensification. Treatment goals and therapies have to be individualized depending on age, functional status, comorbidities, and risk of hypoglycemia. Elderly diabetics need special attention. We need to screen them for cognitive dysfunction, functional impairment, and self-monitoring of blood glucose is a very important access for patients with recurrent hypoglycemia, and conventional risk factors need to be addressed through structured patient education. Thank you.
Thank you, Mainak. You have done a wonderful job. Diabetes, diagnosis to management 360 degree in a presentation. Yeah, there was one single question which you have already answered with your last case, how to deal with CLD when it comes to brittle diabetes. I think we all do agree. There was another question on whether in CLD in child pug C, what would be the drug of choice? I would want you to address that briskly. Child pug C, CLD.
It's better to avoid any oral anti-diabetic agent in child pug C, and insulin remains the safest agent to use in case of child pug C chronic liver disease.
Thank you. Thank you so very much. And before we will go on to the next session, if you remember, we were in Professor Subhankar Chowdhury's office in the morning, and after we visited Dr. Debashish Maji's place, and we saw what Subhankar, Professor Chowdhury had to, the message that he had for the conference. And now today is the memorial oration, and over after the felicitation, I would hand over the, I would ask, rather request Professor Debmallo Shannal to formally introduce after this video Professor Subhankar Chowdhury, and would proceed for the Charles Best Memorial Oration.
Today is 12th February, the second day of Charles Best Memorial Celebration, and we are in the endocrine department of SSKM IPG MER Hospital, perhaps the Mecca of endocrinology, to felicitate none other than Professor Dr. Subhankar Chowdhury, Head of the Department Endocrinology. Professor Anirban Majumdar presents him with a medallion, Professor Debmallo Shannal with a shawl, the modern version of Uttariyo perhaps, and a bouquet and memento by Dr. Ajoy Biswas and Dr. Soumyabrata Chowdhury. Due to COVID situation, this has been pre-recorded live, and we will hear him online in person now.
Thank you, and it's my proud privilege and honor to introduce none other than my teacher, my mentor, as well as somebody who has been an inspiration for all of us in the endocrinology field across India. Professor Subhankar Chowdhury, who is the head of the department in Department of IPGMR and SSKM Hospital, Department of Endocrinology. He's also been the past president of Endocrine Society of India. He has been the founder patron of South Asian Federation of Endocrine Societies, and as well as immediate past president of Endocrine Society of Bengal. He's also the current chairperson of RSSDI West Bengal chapter, and member subject expert committee, Government of India, CDSCO. And his current research interests are, of course, he's there in all fields, but his current research interests are gut microbiome, gestational diabetes, Graves' orbitopathy, and biology of fat in different body compartments. And he has a whopping 207 publications in peer-reviewed journals. So it's over to you, sir.
Thank you very much. Very good evening. Thank you, Dr. Ajoy Biswas, and all in the organizing committee of this wonderful program, ENDIAB Summit, for giving me this unique opportunity to be the Charles Best Orator for this year. Thank you very much. Now the topic, let me start sharing my screen. The topic is on evidence-based medicine. Now, I do remember the organizers were a little bit doubtful whether this would be the best topic for our target audience. I do not know. And besides, what is my claim to fame to talk on this topic? Well, possibly it could be because we started in an era where practice of medicine was, I would say, 80% experience-based and maybe 20% was evidence-based, whereas the pendulum has now swung. And now I think it's the other way around. 80-20 means 80% evidence-based, but still I think about 20% is still experience-based medicine that we practice. But the future generation may be looking at 100% evidence-based medicine. In which scenario possibly, rather than be humans, maybe artificial intelligence will then be in a better position to guide our patients. So maybe that we have seen, our generation, myself would have seen this change in the practice. Maybe that gives me a right to talk a little bit about evidence-based medicine. Now, this does not mean that I am against evidence-based medicine. I hope that's not the conclusion that is taken back at the end of my talk. But I shall try and look at different facts related to evidence-based medicine. So with that, let's go into evidence-based medicine, but do remember at every point, please do consider the patient as a whole, not just individual packets of evidence. And when we talk of evidence-based medicine, we normally automatically associate that with clinical trial. Now, when did the first experiment, which was like a clinical trial, first happen? Was it 50 years back, 100 years back? No. If you look back, possibly the first documented something like a clinical trial, wouldn't call it a clinical trial, occurred around 500 BC. And it was by a person who's not a scientist, who's not a doctor, but a ruler of Babylon, Nebuchadnezzar. Now, he at one point during his reign ordered that all subjects should eat only meat and drink only wine. Now, there were some of the younger generation who were herbivorous, and they protested. Now, normally kings get angry and would say, no, nothing like it. What I have said is right. But this particular man was possibly intrigued, wanted to see what's there. And so what he allowed these people is to go on a diet with legumes and water only. Whereas his dictum in the past was you should have only meat and drink only wine. But they are supposed to come back to him after 10 days only, whatever the duration of the trial. You may maybe differ on the duration of the trial. And then he would reassess. And at the end of it, these young people came back, and according to his criteria, whatever, he felt that they were in better shape, better health than those who were the meat eaters. And so he allowed them to continue with this diet. So this is just a story that trials, trying to look at evidence is something that we talk a lot about these days, but possibly it started several years back. However, it was this entire phenomenon was given a more definite shape by the US FDA's Kefauver-Harris's Act of 1962, or rather the amendment to their Federal Drugs and Cosmetic Act, which happened after the thalidomide tragedy, where we know thousands of children were born with congenital defects because the mothers took thalidomide to treat morning sickness in their early pregnancy. And this necessitated, at least in the US, that every drug company, before they launch any drug, should provide enough evidence of efficacy as well as safety, and also all advertisements or whatever the literature should have clear documentation of these. So that was 1962. So first was 500 BC, now 1962. But when we come to think of the term evidence-based medicine, this hallowed term, I think we can ascribe that to this gentleman, Gordon Guyatt, 1991. So still about 30 years, more than 30 years back. And why evidence-based medicine? I think there is a strong evidence, enough evidence that we need to have evidence in order to treat our patients properly. On the left, we see that there are several thousands of women at one time went through a grueling process, sometimes ending in fatality, of bone marrow transplantation for treatment of breast cancer, based on flawed research, flawed data. And on the right, if you think, it tells us that in the field of clinical medicine, quite often 2 + 2 does not automatically become 4. Now, what I mean is there is enough evidence that the class 1 antiarrhythmic agents definitely suppress cardiac arrhythmias, ventricular arrhythmias. And the other evidence is people following acute myocardial infarction quite often die because of arrhythmias. So people put 2 and 2 together and thought everyone after a myocardial infarction should have a class 1 antiarrhythmic agent prescribed, and this will reduce mortality after myocardial infarction. However, what happened was tens of thousands of people actually died, and the number of people dying because of inappropriate, indiscriminate, routine use of this class 1 antiarrhythmic agents after MI, actually the number was higher than those who died in the Vietnam War in that country. So there again, we need to have proper evidence, not just use a theoretical knowledge with some amount of evidence to decide that this should be in the best interest of the patient. But then how to interpret the results of evidence that comes out of clinical trials? It's sometimes tricky. And this is about aromatase inhibitors versus tamoxifen. Aromatase inhibitors block the synthesis of estrogen. Tamoxifen blocks the action of estrogen in early breast cancer. This is comparison of the two. Now, I don't need you to go into the details of this study, but if you find at the bottom, what we find that for years 0 to 4, during this trial, aromatase inhibitors looked better. But when you come to tamoxifen, or when you came to year 5, it no longer had the edge over tamoxifen. So how do you manage these patients of early breast cancer? So do you use aromatase inhibitors for 4 years and then stop? Or because it should benefit over 4 years, should we not continue the same? So this is something that needs something beyond even the evidence. And so when we talk of evidence in evidence-based medicine, we always look at this hierarchy, and on the top, the pinnacle is RCT, or randomized controlled trial. But there are different other bodies of evidence as well. And at the very bottom is expert experience that I said possibly is what ruled our days, the initial days of practice of medicine. So RCTs versus expert evidence. And there is a system to look at evidence. There is GRADE, which looks at how to sort of to assess the reliability of the evidence. But we do need to remember that not all the data that we need can come only from a randomized controlled trial. For example, what about patients on dialysis? So do we stop dialysis in half the patients and continue dialysis in the other half, and then decide what are the end results? Similarly for hip replacement, similarly for diabetic ketoacidosis requiring insulin. So many a time we need also to depend upon observational study, which however has to be of sufficiently high quality. So it's not just randomized controlled trials which will give us an answer. And then about the limitations of evidence-based medicine, we all have heard the limitations of randomized controlled trials, that the trials have strict inclusion and exclusion criteria, so they may not represent the patients that you and I see every day in our clinics. quite often the elderly and women are underrepresented in clinical trials. And remember, at least 1/3 of all MIs, myocardial infarctions, occur in those above 75. But if you look at clinical trials related to MI, they account for only about 9% of the trial subjects. So real world evidence comes to be published, which would suggest that RCTs are possibly unreal. And we base many of our decisions on randomized controlled trials. The other issues are for most anti-diabetic drugs, anti-hypertensive drugs, we have clinical trial evidence for maybe for 5 years, if it's a long trial. However, we use these drugs for 20, 25, 30, 35 years. So do we have the evidence actually for usage beyond 5 years? We don't, but we do that. And that's again, using your maybe mental faculty and trying and extrapolating, which is nothing more or nothing grossly better than possibly so-called experience-based medicine. Then we have evidence for drugs in isolation, but many a time we use drugs in combination, both in hypertension and diabetes, and continue till long. So these are issues that we need to consider when we try and interpret the importance of evidence-based medicine. The other very important factor that we need to consider is the difference between statistical and clinical evidence. Now, we all think if p-value is less than 0.05, then it's magical, then it must be the final answer. But we do need to remember that what about p-value of 0.055 versus 0.045? So 0.055 will be rejected, 0.055 will be embraced, accepted. So in reality, I think the differences will not be so much, but for practical reasons, we need to draw a sort of cutoff line and say this is effective and this is not effective. And then there's the real issue of looking at evidence. Most pharma industry usually would like to make the data look very impressive to us. So they will highlight the relative risk, improvement in relative risk. So many times the absolute risk reduction may be 1%, 1.5%, 2.2%, whereas the relative risk reduction may be 35, 40, 50%. And that is what will be highlighted before us in order to make us accept a new form of treatment. But these are issues we should keep in mind. It's not to say that we don't look at the evidence, but try and make a proper balance of what you are looking at. Similarly, when we talk about statistics, we need to remember that many a time, for example, in any normal range that we think of, and here I have put before you the normal range of thyroxine in population. If you look at the laboratory reference rate, it is quite broad. But for a given individual, the normal range could well be within very narrow limits. So these are, once again, the limitations of just using statistics and deciding that statistics rules everything. Possibly it does not, unless we really understand well. And then a little bit more about the limitations of evidence-based medicine, especially if we straight away from one study itself, we come to our conclusion. For example, the effect of spironolactone on morbidity and mortality in patients with severe heart failure way back in 1999, which showed that mineralocorticoid receptor antagonist like spironolactone could go a long way in reducing mortality, long-term improving not only the symptomatology, but also possibly improving longevity in patients with heart failure. However, and it was well accepted in various guidelines, but the paper to actually show the risk of hyperkalemia came much later in 2004, whereas the first paper was 1999. So we need sometimes got to take our final decision, maybe not immediately after publication of a paper, but maybe looking at different other papers as well. And then about use of low-dose aspirin. Now, in recent times, this has become less used in cardiovascular event prevention. And where we do find in terms of cardiovascular death reduction, aspirin versus noraspirin, there is a significant benefit. However, there is also increased risk of serious bleeds. So do we use aspirin in a given individual or not for cardiovascular risk reduction will depend not only on the cardiovascular risk factor, but also a whole host of other factors, including the risk of GI bleeds. And so will require consideration of the overall condition of the given individual. And then another limitation of evidence-based medicine is the bias of the easily measurable. We can measure weight, height, blood pressure, blood glucose, cholesterol, this and that. But objective data does not consider the less tangible, the quality of care, the patient's experience, so on and so forth, patient's wishes. And we also need to remember that ill health is not a binary phenomenon. It's not just the presence or absence. There could be so many shades of gray in between. So these are, again, possibly beyond the realms of evidence-based medicine. And then I come to a very important study, the Look Ahead study, which looked at the effects of intensive lifestyle intervention in type 2 diabetes for cardiovascular benefit. And it was decided at the end of 9.5 years of follow-up that this trial was stopped because it suggested no improvement of cardiovascular events in overweight or obese adults with type 2 diabetes. So this is widely taken as a negative study. What I'm trying to argue is, shall we consider that this is a negative study? Now, see, this led to weight loss. This led to improved biomarkers of glucose and lipid control, less sleep apnea, less liver fat, less depression, less urinary incontinence, reduced need for diabetes medications, better maintenance of physical mobility, improved quality of life, and lower costs. So quite often, while the pharma industry may want us to believe that it's statins only that can help, others are not of importance. I think it's important to look at the trial overall and not just maybe that's the primary endpoint was, of course, looking at cardiovascular events. But so many positives have emerged from this Look Ahead trial. And now I go to the opposite sort of spectrum of our conclusion from a clinical trial. So this is the DIRECT study, which was published 3 years back by Michael Lean and his group. But we all know it was Sir Roy Taylor, who actually led this group, looking at primary care-led weight management for remission of type 2 diabetes, the DIRECT study, and which showed that at 12 months, almost half the participants, actually 46%, achieved remission to non-diabetic state and off anti-diabetic drugs. And remission of type 2 diabetes is a practical target for primary care, was the conclusion. And remember, this is not a pharma company directed study, initiated study. This was by UK, Diabetes UK. And look at the response to this. Now, there are so many papers, including a narrative review of the evidence for reversal of type 2 diabetes. And now if you Google reversal of type 2 diabetes, you see at least a score of advertisements which will entice you to enter this program or that program for type 2 diabetes reversal. So do remember that the BMI that they looked at was clearly significantly higher than many of our patients that come to our clinics. And the sustenance of weight loss is really difficult, at least in my personal experience over the last so many years. So other issues with evidence-based medicines would be medicalizing issues that are a natural accompaniment of life, like andropause. Quite often in trials, an inferior comparator, placebo, is compared to an active agent, and then misrepresenting small events as major breakthroughs. Finally, I would like to draw attention to the fact that evidence-based medicine itself, if you come to think of it, is not evidence-based in the sense that, have you ever compared that using one drug on the basis of evidence-based medicine and another drug not used based on EBM, is there a difference between the results? I don't think we have such sort of data. And then, please do remember, more than 10 years back, when this glargine insulin, this wonder drug, Alantus, came into our lives, we were taught that this is the true 24-hour insulin without peak, absolutely flat action profile. And we have, all of us have parroted this in numerous meetings thereafter. Now, what happens after 10 years when the period of exclusivity comes to an end? You now have another glargine, which is U300, more concentrated, which now has taken the place of the original Lantus, which now says, this is now the real insulin that gives you 24 hours peakless profile. So either we were fools then, or we are fools now, or maybe we'll remain fools all through unless we look at evidence properly. And then quickly, I'd like to, we'll try and sort of come to the end of the talk. So now, once again, Canvas program is about one of the SGLT2 inhibitors, which did show that significantly, which was actually the only one amongst the three major SGLT2 inhibitor CVOTs, which showed that overall the primary 3-point MACE reduction was significant with canagliflozin. However, if you look at the data, you find while together death from CV events, non-fatal MI or non-fatal stroke was significantly reduced, individually, the drug did not significantly reduce either death from CV causes or non-fatal MI or non-fatal stroke. So this is about statistics. If you put these three together, then it becomes significant, but individually it does not decrease any of them, even statistically significantly. And then we need to remember that there can be negative trials, and so there can be reporting bias in medical research. 50% of research was never published. However, internationally it was recognized, and BMJ editorial, this was some time back in 2013, mandated that all trials must be registered and the results published. So this negative results being suppressed would possibly not happen these days. But I wish also to bring all of us aware of the tremendous force possibly of the pharma industry. Now, we all know of the Cochrane collaboration about serving us evidence-based medicine, set up in 1993. But not too long back, one of the actually founding members of Cochrane, Peter Goetze, from the Nordic Cochrane Center in Copenhagen, he made a lot of noise about interference by pharmaceutical industries. And possibly as a result, of course, I don't have inside information, he was voted out of the Cochrane committee because of his disruptive and inappropriate behaviors, which eventually, of course, also led to 4 other board members to resign. So clearly we have a strong pharma mafia, maybe. I'm sorry, forgive me for using strong words, which we also need to be aware of. We need to be aware of the requirements for a reliable research. It is there. And finally, as practicing physicians, do not be overawed that you need to keep track of so many different trials, evidence, and look at them so carefully. Second order peer review of medical literature for clinical practitioners can also be quite reliable. And so eventually the clinician, the busy clinician may not need to read up each and every trial that comes, but we need to rely on reliable second order peer review. And so finally, ladies and gentlemen, I bring you to this fresco by Raphael in the Vatican, which has on the left the Guru Plato with his finger pointing up towards heaven, whereas his pupil Aristotle has his palm turned down towards earth, sort of differentiating between the two approaches, or more practical approach of the newer generation Aristotle. As clinician, I think we need to keep our foot in both the camps and provide the best possible treatment, honest judgment for our patients. With this, I would like to thank all of you once again for providing me this opportunity. I'll stop sharing, and I do hope it made some sense to whoever cared to join. Thank you very much.
Thank you, sir. Thank you, sir, for that mesmerizing talk. And of course, the word mafia today is very relevant, being a day of elections in the city. It was not out of place. Thank you, sir. And as this is an oration, I must acknowledge that this session was supported by USV, and oration does not, the talk is not followed by questions. Thank you, sir, so very much for being with us, for giving time in the morning during the inaugural session, and we can't thank you enough. So we come to our next session, which is management of hospitalized heart failure, reduced ejection fractions, case-based discussion on cardiac remodeling, and none other than Dr. Aftab Khan, who is a senior consultant, interventional cardiologist at the Apollo Clinicals Hospitals, to take it up with us.
Yeah, thank you. I would like to then get permission to share my screen.
Yeah, please.
Okay, are my slides visible?
Yeah.
Okay. Thank you for being here and giving me this opportunity to put in a few words here. So I think my topic of discussion is the management of hospitalized heart failure reduced ejection fraction patients. And I'll try to keep it a case-based discussion. And what we are trying to target here is the role of cardiac remodeling in patients with heart failure reduced ejection fraction. So when you talk about patients with heart failure reduced ejection fraction, I think we are all talking about patients who have an ejection fraction of less than 40%. And I think this differentiation is necessary because now we have these different heart failure criteria which have been set up. And we are also talking about patients who have heart failure with preserved ejection fraction, where the cutoffs are usually beyond 50%. So when you talk about patients with heart failure, we know that there's something known as cardiac remodeling that sets in. And this is what is the basic pathophysiology in patients with heart failure. And the various pathological and the physiological stimuli affect the cardiac tissues in multiple fashion. And when you're talking about the tissues, well, it's not only the cardiac tissues, we are not talking about the cardiomyocytes and the ventricular myocardium itself. We're also talking about the vascular smooth muscles and the endothelium. And all of this also has an effect in the way that the myocardium really works in terms of its pathophysiology and creating a patient with heart failure. We also understand that there's, in addition to the various macroscopic changes, there are cellular level changes also, and there's cell death or apoptosis, and of course the effect of RAS inhibition, the excessive beta blockade, the sympathetic overdrive, which also causes all these pathophysiological changes. We also need to understand that the event of left ejection fraction reduction eventually results from a change in the myocardial mass and the volume. So once we have LV dysfunction, there is a reduction in the LV mass, and there's also an increase in the LV volume because of the fact that there is retention of myocardial blood or inside the cavity. So when you have LV dysfunction, there is an increase in the left ventricular end systolic volume index and the end ventricular end diastolic index, along with a reduction in the left ventricular ejection fraction. And as I said, we all have studied from our days of physiology that it's a vicious cycle, and myocardial injury is only one of the pathophysiologies in this cycle or cascade, which involves multiple organs, which involves the sympathetic system, the nervous system, the renal system, as well as the myocardial system itself. So hypertrophy and reverse remodeling in heart failure is usually a manifestation, and that results, as we said earlier, in changes from the cardiac structure, from the myocardial composition, and also the vascular changes that happen inside the cells. And all of this affects the cardiac function and its reserve capacity. So once we start understanding the pathophysiological changes of myocardial remodeling, we know that this could be a target for us to make sure that we can improve the prognosis of our patients with heart failure and help them to live a better quality of life. This is a case scenario of a gentleman, an elderly patient with heart failure, reduced ejection fraction, was recently hospitalized because of a heart failure event. And this is a gentleman who was initially doing well, but then he had a little difficulty in his activities of daily living. But then he had an episode of unconsciousness and was rushed to the hospital, where he was diagnosed as having a heart failure with reduced ejection fraction. His echo ejection fraction was 32%, way down from the 60% that we know is normal. His global longitudinal strain pattern was 15%, and his NT-proBNP, a marker of fluid retention, is sky high at 1,782. The echocardiography, which now is becoming the essential tool for us to assess these patients of heart failure and to differentiate between, as I said, heart failure reduced EF and heart failure preserved EF. Well, this gentleman, along with the reduced ejection fraction, had increased left ventricular end diastolic volume index and left ventricular end systolic volume index and left atrial volume indexes. So all of these indicate that there is a poor LV contractility and an increased LV retention of blood in the various chambers. Well, this gentleman was hemodynamically stabilized, and then it was necessary for us to initiate the right therapy for him so that we can do something to improve his prognosis. And all of this prognosis is based on the ejection fraction. So cardiac remodeling and heart failure is now a major target of treatment with all our other drugs. And this remains a major factor in prognosis in patients with heart failure. And as I said, it's a vicious cycle. Once you have a myocyte damage and matrix damage due to a myocardial infarction, and this is the commonest cause of LV dysfunction in majority of the patients worldwide, ischemic heart disease and old myocardial infarction. And this produces a cardiac remodeling, which is often, as I said, interconnected with the excessive sympathetic overdrive, and along with the cell death, the fibrosis and the hypertrophy, which happens as a compensating mechanism. And all of this results in an inappropriate remodeling and progressive aggravation or deterioration of LV function, eventually resulting in further deterioration of his LV function and presentation with heart failure. So three major criteria that we look at is the LV systolic function. We also look at the LV diastolic function, and we also look at the shape of the mitral valve, because all of this has a bearing on the filling of the ventricle as well as the total effective cardiac output. So left ventricular systolic function is something that is very easy for us to understand. A weak heart cannot pump adequately, or it cannot pump an enough amount of blood to maintain circulation to the peripheral system, even under conditions of increased stressors. So LVEF, or ejection fraction, is a common marker which is most commonly utilized, and I think an echo is the most common way that we look at our criteria of LV ejection fraction. We also look at LV end diastolic volume, or LV end diastolic dimensions, to understand the degree of systolic function and the degree of structural remodeling. whereas end ventricle, left ventricle end systolic volume or left ventricle end systolic dimensions are the best way to understand what is the amount of systolic dysfunction. So when you have a patient who has a poor LV function and his left ventricle is less contractile, there will be an increased amount of volume that is left behind in the ventricle because the blood is not ejected out from the ventricle. The shape and the function of the mitral valve, or coming before that from the systolic function to the diastolic function, we also need to understand that the blood has to enter from the mitral valve, from the left atrium to the left ventricle across the mitral valve, and the left ventricle has to be receptive to receive the blood that has to come in from the left atrium. And in these patients, when there is a restrictive pattern, when there is myocardial damage, the left ventricular end diastolic pressure tends to be high. The ventricles are stiffer, and therefore there is a reduction in the mitral inflow. And this left ventricular diastolic dysfunction is something that reflects in a mitral inflow pattern, and this is often that of a restrictive inflow pattern, which is seen on an echocardiography as an E/A ratio, which is more than 2. And similarly, by means of looking at the mitral valve regurgitation, because there is an LV dysfunction, there is a dilatation of the mitral annulus, so there is a coaptation failure, which often results in a functional mitral regurgitation, or in patients with inferior wall MI, when there is a damage to the papillary muscle and the subvalvular tissues do not coapt well. So this also leads to an organic mitral valve disease. And both of this, the mitral valve annular dilatation, as well as ischemia of the papillary muscles, could contribute to an increased amount of mitral valve regurgitation, all of which compromises the functional flow or the forward flow, because when there is a contractility and with MR, there is more of a backward flow rather than a forward flow, which results in a lower amount of cardiac output. So cardiac remodeling is to be assessed, and this is something that we do by echo, and especially when the patient is in the hospital. But again, what we need to understand that even in hospitalized patients, progression of an underlying cardiac disease with ventricular remodeling is an important cause of acute decompensated heart failure. And as we said earlier, our echocardiographers are very important in our decision-making planning process. They help us to guide the management, and it's important that we get a good echocardiographer to look at the echo and give us these small features. MR which is missed out, or a wall motion abnormality that is missed out, could make a difference in the way that we treat these patients. And again, these parameters, and not only the ejection fraction, because the ejection fraction is sometimes calculated in many machines, and it sometimes is a visual estimation by many people. But what we do is often look at the other parameters, as we said earlier. We look at parameters of systolic function, we look at the volumes, and we often mention the diastolic filling patterns also. Why it is important is that the remodeling patterns are not only assessed or tell us about the event that has happened now, but they also predict the amount of CV events that are likely to happen in the future. So when we look at patients who have normal remodeling patterns, with patients who had concentric remodeling, eccentric remodeling, what we see is that patients who had a remodeling that has happened, and this is the black and the yellow, you can understand that patients, unlike patients who had normal events, normal echoes, we can see that all the events are much greater when there is a remodeling that takes place. And often the concentric hypertrophy is less dangerous than the eccentric hypertrophy that happens many times in patients who have an myocardial infarction. And again, to come back to this point of remodeling, the risk of CV deaths and heart failure hospitalization increases significantly, and the ejection fraction of less than 40% was studied. Candesartan, which is an ACE inhibitor, when it's an ARB rather, when candesartan was used in patients, and what we found is that patients who had an ejection fraction, even if it fell by less than 10%, and when there was a remodeling that took place, the outcomes were much worse. The cardiovascular death increased dramatically as compared to patients who did not have a poor ejection fraction, or who had an ejection fraction which was closer to 40%, as compared to patients who had an ejection fraction which was much lower than the 40% with remodeling. And similarly, as we said, the risk of heart failure, hospitalization, and death increases with an increase in the diastolic and the end systolic volume. Again, a small change in the end diastolic volume, which all indicate a poor ejection fraction, can all reflect in a higher mortality. So not only just hospitalization, we are looking at hard endpoints of even heart failure, death, and hospitalization that happens once there are changes in the LV end diastolic and end systolic volumes. And this has been proved in many studies. Therapy devices are devices that help to synchronize the heart by means of a device that is placed percutaneously. And what this does is that it helps to synchronize the heart. So once you achieve an AV synchrony or atrial ventricular synchrony, and you achieve a septal to a wall, lateral wall synchrony, what you do is that by remodeling or causing between these various chambers, you help the remodeling of the ventricle. So the ventricle, which otherwise would have bulged in one of the walls because of its contractility, once you give a stimulus and you help the wall to move synchronously with the septum, you often help in the remodeling that happens. And as a result of which, what we get is that once there is a remodeling or improvement in the remodeling that happens over a period of time, you can see that the mortality rates definitely come down. So when you look at patients over a period of time, as compared to patients with a degree of improvement in the ejection fraction. So here, as the ejection fraction improved, you see that there is a reduction in the mortality over a period of time. And this is then the same study showed that as you reduce the left ventricular and systolic volume, so as the ejection fraction improves, what would happen is that the systolic volume would reduce, the more blood is getting pumped out from the left ventricle. So once we see that over a period of time, as the left and systolic volume reduces, you see or a reduction in mortality. So as the left ventricular systolic volume increases, you see an increased mortality. Once the left ventricular systolic volume increases, you see that there is an improvement in mortality. So devices are, of course, a way to do that. But do we rush to put in devices in all these patients? The answer is no. And what we would do is to try optimal medical therapy. And do we have such therapies which work to help patients like these? Well, we know that over a period of time, we had ACE inhibitors and ARBs as our first-line drugs, along with the beta blockers. But now we have a molecule for almost close to 5 to 10 years now. And this is the army that we're talking about, the combination of sacubitril valsartan, which helps to improve cardiac remodeling. Well, are these drugs better than ACE inhibitors? And that's a question that we often ask because of the fact that these drugs are more expensive. And many of our patients are probably doing well on ACE inhibitors. And that's a question that all of us would think, is it worthwhile shifting a patient who's doing well now on ACE inhibitors and ARBs? Do I make a switch onto ARNI now? Well, the answer is that we have trials now which have shown and now they are the class 1 indication to be started over and above ACE inhibitors. There's a patient who's stable on ACE inhibitors and ARNI. I would still say that these patients should be switched over to an ARNI rather than leaving them on ACE inhibitors alone. What is the reason for this? The reason is that ARNIs are a combination of two drugs. So there's an ARB here, there's the combinations of them have different areas of action. So all of this, to cut short this of action, we know that there is a reduction in cardiac myocyte contractility, and all of this which happens in patients with heart failure, the remodeling is improved by use of these drugs. And therefore, this is the drug that I was talking about. And when there is a trial which has looked at head-to-head, so an ACE inhibitor ARB with a sacubitril valsartan in patients with hospitalized. So there was initial concern that we should take use of these drugs only after the patient is stable, only after the patient gets discharged from the hospital. But now there's enough data to say that we do not wait to stabilize these patients on ACE inhibitors and then make the switch. We would say that now the guidelines suggest to start ARNI as early as possible in the patients who are even hospitalized. So we do not need to wait to stabilize them with an ACE inhibitor first and then switch to ARNI. We would start with an ARNI in the hospital. And this approach, as compared to an ACE inhibitor or an ARB, has resulted in an improvement of almost 7.5% in improvement in ejection fraction. And we know that each improvement in ejection fraction makes a difference. So an ejection fraction of 30% and an ejection fraction of 35 to 40%, well, the patient who has an improved ejection fraction is likely to live much better and live longer. So not only is the quality of life better, its risks of having sudden cardiac death are also much lesser. once the patients have an improvement in their ejection fraction. And the same study has also looked at the echo parameters also. And as I said, as compared to ACE inhibitors or ARBs, sacubitril valsartan had an improvement in the patient's end diastolic volume, end systolic volume, the left atrial volume, and the diastolic flow patterns. There's another parameter on an echo, and I believe that we may not be, so many of our people who have logged in may not be echocardiographers, but echocardiography has moved long ahead. And what we look at is also the global longitudinal strain pattern in patients when you're doing heart failure. And this strain pattern is used as a reliable and as an objective method to assess systolic function. So there's a spectral tracking that is done, and this provides an information on this segment. So I think this is again something that is more relevant to patients, to people who are doing echoes. But what we need is a parameter that you should also look at once you are treating a patient with heart failure. And the global longitudinal pattern helps in predicting mortality and readmission in the various studies. And again, as I said, this is again one more study where we looked at the global longitudinal strain, and they found that this is an independent predictor of heart failure hospitalization. Patients who had with a higher global longitudinal strain pattern had a higher risk of having heart failure readmission. Again, this is a study which had looked at reduction in the GLS, and it found that patients with on a follow-up sacubitril valsartan was much better significantly as compared to ACE and ARBs in reducing the global longitudinal strain patterns in patients with heart failure. So to summarize, I think what we need to understand that these patients of heart failure, we really have lots of choices. We now have ARNIs. We also know that beta blockers. We also have the corticosteroid antagonists, and we now also have SGLT2 inhibitors. So one needs to understand that with this armament that we now have, hospitalized patients with reduced ejection fraction with an impaired, as I said, LV dysfunction in this group of patients, it's important that we start using these drugs in an early course of our disease. We do not wait till the LV function really deteriorates. ARNI, for instance, has proven to its benefit with multiple, there have been multiple controlled trials which have been done, and these are now class 1 indications or the first line therapies in patients in ACC as well as the ESC consensus guidelines. Thank you for your patient hearing, and I'll stop here and take questions if there are any.
Thank you, Dr. Khan, for your deliberation. I'll just come back to you with a couple of questions after a brief video.
Hello and welcome to this year's ENDIAB Summit 2022 on occasion of Charles Best Memorial Day. I'm Dr. Kullan Kumar Gangopadhyay, one of the faculty. It really gives me immense pleasure in welcoming the delegates for this excellent conference. It is excellent in the sense that all the topics have been so nicely selected that they are very practical, and I'm sure all the delegates would be able to utilize what they are studying or what they're reading or what they're understanding from these topics, and they can apply that the next day when they go to their hospital or their respective clinics. There has been a very good, nice choice of speakers who are doyens in their respective field to address this issue. So don't miss it, ladies and gentlemen, and welcome once again.
Dr. Khan, thank you so very much. And there's just one question which is there in the chat box, but I think it will take you some time to answer. Till the emperor preserved, we had nothing for heart failure preserved ejection fraction. And Paragon heart failure kept side by side, perhaps fell a wee bit short of the results desired for. So in a patient with heart failure preserved ejection fraction between 50 and 60%, keeping the Paragon heart failure and the Emperor preserved trial in mind, what would be your initial choice of anti-heart failure therapy?
Yeah, I think this is a tough question. I think itself it requires another lecture when you talk about heart failure preserved ejection fraction. So unlike the heart failure reduced ejection fraction, where, as I said, we now have drugs in our armamentarium. We now have these big four, the ARNIs, we have the MRAs, beta blockers, and the SGLT2 inhibitors. I think in the patients with heart failure preserved EF, we are still not looking as good as we would probably be doing a few years back. But I think what is most important for us is to realize that these patients with heart failure reduced ejection fraction with patients with preserved ejection fraction, these are two different subsets of patients. So preserved ejection fraction, usually in the reduced ejection fraction, I think it's very simple. You have LV dysfunction, you have an MI, you have these patients who have a scar on the ECG or on the echo, and you know what to do with them. Whereas these patients with preserved ejection fraction are patients who are usually more elderly. They're the hypertensive, they're the patients with CKD, they're the patients who have arrhythmias, and these are the patients who have atrial fibrillation more commonly. So these are the patients where sometimes the treatment of the primary pathology also plays an equally important role. So when you have atrial fibrillation and patients with preserved ejection fraction, well, as we know that in patients with LV dysfunction, the atrial fibrillation does worsen the arrhythmia, does worsen the heart failure, but equally so in patients with preserved ejection fraction. I think we also need to set our targets to treat the associated comorbidities. So treating your renal failure, treating your arrhythmias, treating your anemia, all this becomes more important. Well, coming back to the tools that we have, again, I think as you said very clearly, Dr. Orator, we are still in the dark. I think diuretics still play the major bulk of our treatment protocols and patients to decongest them or treat them with symptomatic. We now have something to grope onto. And of course, as I said, we do have some data from the preserved, as you said, the SGLT2 inhibitors can be used in this group of patients. ARNI also, as there have been studies where we have seen that a particular subset of patients with ARNI, and especially the women, where probably in the preserved EF you may still have a benefit. Again, the subgroup analysis of these studies have showed that in a particular subset of patients with an ejection fraction that is beyond 57%, you could still have some benefit with ARNI. But do I start with these patients with ARNI as the first line? The answer is no. So as much as my confidence is in patients with reduced ejection fraction, well, in the patients with preserved ejection fraction, I think we still have to have a clear discussion with the patient. These are drugs that are expensive. These are drugs that often we use with some conviction. And I think it's important that we discuss with the patient, tell them that the data is limited. And these are sometimes drugs which we do try once the patient agrees, but we often have to understand that the associated comorbidities are sometimes easier to treat and get more benefit rather than looking for a magic pill.
Yeah, I totally agree with you. And I think that the time has come that we particularly disseminate knowledge about how to diagnose heart failure preserved ejection fraction. Right. Yeah, because that is very important. More than because we have limited choices, diuretics would give you symptomatic relief. Yes, at times it's difficult for us to treat the comorbidities to a satisfactory level that might take care of the heart failure. Thank you so very much. Again, taking the patient into confidence becomes important. Sharing the data with them becomes important. And thank you for sharing your time with us and your expertise. Thank you so very much. We loved it.
Thank you for being here.
As we come to the end of the second day, the diabetes is at an end and tomorrow the endocrine is going to start. So spectrum of insulinization, what more could be used to treat diabetes? It's 100 years of insulin discovery, and what an appropriate topic to end the second day of the diabetes related topics of ENDIAB Summit. Tomorrow at 9 a.m. it would be an endocrine day altogether till 1 in the afternoon. And to present to us is Dr. Indriya Maisnam, who's DM in endocrinology, FRCP Edinburgh and FACE USA. She is a senior consultant endocrinologist, Department of Endocrinology, IPG, MER and SSKM Hospital, Kolkata, Charnock Hospital, Bellevue Clinic and RSV Hospital. The clinical and academic experience of 17 years backing her up, and of 52 publications in peer-reviewed national and international journals. Over to you, Dr. Indira.
Thank you very much. Thank you for having me here in this unique and special meet. So my topic, as has been announced, is spectrum of insulinization from hospital admission to post-discharge. So these are the agenda for discussion: the relevance of good glycemic control in hospitalized patients, understanding need for managing both the components of dysglycemia, that is the fasting as well as the postprandial, and managing hyperglycemia after the discharge. So glycemic control in the hospitalized patients is very important because the poor glycemic control is associated with increased risk of mortality, we know. So this is the mortality this is one study which showed the mortality in patients with normal glycemia, with known diabetes, and with newly discovered hyperglycemia, where we see that the newly discovered hyperglycemia was associated with a greater risk of mortality. Also, not only is the hyperglycemia important, but the degree of glycemic variability is important. The greater the glycemic variability, there is increased length of hospital stay and increased mortality. Therefore, managing hyperglycemia in the hospital setting, anti-hyperglycemic therapy, in most of the conditions, we would be using insulins, and OADs, except for very, very rare conditions, would not be recommended mostly. Now, how do we use insulin depends on whether our patients are critically ill or non-critically ill. In non-critically ill patients, typically they would be provided a basal bolus insulin, and critically ill patients could be offered anywhere between a basal bolus insulin or even an IV insulin infusion. So there are glycemic targets for hospitalized patients. The threshold for starting insulin is when the blood glucose is more than 180 milligrams per deciliter. We know that the target blood glucose in the hospitalized patients is around 140 to 180 milligrams per deciliter. There could be some, let's say, adjustments in the glycemic target, a little higher level in those who are terminally ill with severe close comorbidities and when close nursing supervision is not feasible. Similarly, the RSSDI from our country has also similar recommendations. So the anti-hyperglycemic treatment in patients, in hospitalized patients, depends on what the patient is suffering from, how severe is the illness, and also how is the nutrition of the patient being taken care of. So if the patient is poor oral intake or NPO, many times we give an infusion or we give a basal insulin with a correctional dose insulin regime. If the patient has a good nutritional intake, then we give what is typically known as the basal bolus regime along with the correctional components. But one thing which is still practiced and which should be actually discouraged is the sliding scale insulin, which should be strongly discouraged. So if we see the changes in the blood glucose concentrations in patients treated with a basal bolus regime, we see that there is a marked improvement in the blood glucose with very little glycemic variability. But in someone who is rapidly improved after switching to a basal bolus insulin regime. So the basal bolus insulin regime is preferred over the sliding scale in the management of non-critically ill hospitalized patients with type 2 diabetes. Now, what are the criticisms against the sliding scale insulin regime? So it is non-physiological. Patient experiences a roller coaster ride of blood glucose, suffering between swings of hyper and hypoglycemia, as we can see here. There is poorer glycemic control and increased risk of both severe hyperglycemia as well as hypoglycemia, and it is not individualized, and this is a reactive approach in the sense that the action of correcting the blood glucose is taken only when the blood glucose has risen up to a certain level, or in other words, when the damage has been caused. So the basal bolus regime is superior because it's a physiological way of glycemic control, because we know normally physiologically we have a basal insulin secretion in our body, and there are boluses of insulin secretion which coincide with our meal timings. And therefore, not only ADA, but most of the authoritative body recommend the basal bolus regime in inpatient setting. So that addresses many components of the hyperglycemia. That is, the basal would specifically target the fasting state insulin requirements. The bolus would target the mealtime insulin requirement, and the correctional would address the unexpected glucose elevations or dispose of elevated hyperglycemia. So in most of the cases, implementing basal bolus therapy to manage inpatient hyperglycemia in non-critically as well as critically ill patients will improve the glycemic outcome with fewer hyperglycemia and hypoglycemic agents. So when we give the basal bolus regime, we typically calculate the ideal dose of insulin in somebody, an insulin naive person, as something like 0.4 to 0.5 units per kg of the ideal body weight. Somebody who is obese would need a greater amount of insulin. This is the starting dose of the total daily dose insulin requirement. And these would be adjusted based on the capillary blood glucose monitoring, which we would do. So typically, after calculating the total dose, around 40 to 50% is given as bolus, basal, and another, let's say 50 to 60% is given in bolus, which is divided typically into 3 major meals. And then we measure the blood glucose, typically pre-meal, but also post-meal, to understand the insulin response in these individuals. Sometimes we may have to measure the blood glucose at, let's say, 2 a.m. or 3 a.m. to look for the nocturnal hypoglycemia. And then we adjust the insulin level dosing based on our target blood glucose, which in most of the patients is 140 to 180. So this is just an example of correctional insulin protocol. It's not necessary that we follow it as a hard and fast rule. There is, in every person is an individual. Every person's response to insulin would be different, and therefore individualization is the key to good insulinization and good glycemic care in patients. So in hospital requirements, the basal bolus is effective glycemic control, lower risk of hypoglycemia, flexible and simple dosing, and usage in the entire range of population. So, and if we look at the typical basal insulin, for example, the degludec, it targets the fasting glucose so well, as we can see after starting at admission, and on day 4, by that time, the fasting blood glucose is very well reached, and the average blood glucose at admission and at discharge is so well improved with the use of degludec, where we've seen that there is a mean change of fasting blood glucose, as we can see here. And also, not only does it improve, or let's say lower the blood glucose to normal, it also reduces the glycemic variability, as we can see here. And the average mean glucose in this example is 152 milligrams per deciliter, with a range between 115 to 195, showed that it is a good predictor of not only a good glycemic control in the sense that it targets the fasting well, but also decreases the glycemic variability to a favorable extent. So this is about an example of a basal. What about a bolus? So the bolus could be the human regular insulin, or it could be the analogs like aspart, lispro, or glulysin, or let's say the ultra rapid acting analogs like faster aspart, which we know is available as FIASP, and we are using it, I think, quite a lot in the hospitals these days. So it has got compared to, let's say, a rapid acting analog, this ultra rapid acting analog FIAS is associated with greater reduction in the postprandial glucose, and also in the as we can see here, the expected treatment difference is around 0.1%. Also, combined with the degludec, there is a lower risk of hypoglycemia, and therefore combining a basal bolus insulin like, let's say, a degludec with a fast-acting aspart results in targeting both the fasting as well as the postprandial, with a decreased chance of hypoglycemia. So this is what the slide is trying to show, that there is a decrease in the overall hypoglycemia, the daytime and the nocturnal hypoglycemia. And also there is a marked flexibility in the case of daycare procedures with degludec, where this CGM study, which was done in patients who were undergoing a total colonoscopy, showed that the use of degludec resulted in stable glycemic profile, and no patients undergoing the colonoscopy experienced hypoglycemia during the fasting period of 24 hours with degludec. So insulin degludec can be used safely prior to the procedure requiring NPO with the least chance of hypoglycemia, because it more or less, to a large extent, mimics the typical basal insulin secretion profile that occurs in normal individuals. Again, the beauty of faster acting aspart is that, yes, it addresses the postprandial hyperglycemia. There is lesser chances of delayed hypoglycemia, and also because it can be just given before the start of the meal or even after the start of the meal, it is very convenient for the patient, especially in the hospitalized setting, when we are not aware when the patient would take the food or how much food the patient would take, and things like that. So even giving it after the start of the meal is a very could be a preferred option in hospitalized patients. And again, used in a wide range of population, whether patients are uncontrolled diabetes, whether they have renal impairment, hepatic impairment, elderly, and pediatric group. Now, coming to the understanding the need for managing hyperglycemia. So if you look at the impact of the COVID-19 related lockdowns on the glycemic parameters in the Indian evidence, it's not only Indian evidence, it's throughout we know that the COVID-19 the lockdown itself has resulted in worsening of the blood glucose control because of lack of physical activity, because of, let's say, not visiting the healthcare setup regularly. And so these are the papers from India where it was found that carbohydrate consumption and frequency of snacking actually increase in the patient, resulted in weight gain, and also the exercise duration decrease because of, let's say, fear of going out because of the pandemic, etc. And during the lockdown, postprandial blood glucose levels increased significantly with in this study, but also overall there was worsening of the glycemic control. Now, high postprandial and high fasting contributes to both the HbA1c, and this could be because of the fact that because of many factors. One of the important factors could be that there is delayed insulin initiation, or even if the insulin is initiated, typically initiating with a basal insulin in a, let's say, in an OPD setting may not address the postprandial hyperglycemia that is typically associated with our Indian diet. So the choice of insulin initiation should take into consideration, this is in the OPD settings actually, the Indian realities, which is high carbohydrate diet, high postprandial glucose level, patients uncontrolled on multiple OADs, and need for safety and convenience. So in the outdoor setting, in the OPD setting, can OD basal insulin is enough be suitable in the case of a high carbohydrate diet or for direct control of postprandial glucose? No. Is it suitable in case of delayed insulin therapy? In delayed insulin therapy, both the prandial as well as the fasting, postprandial as well as the fasting glucose are increased, and would only a basal insulin affect control the total or the fasting and postprandial glucose? So a combination of quick release prandial insulin with slow release basal insulin could be the ideal combination. Before this combination arrived, we have already been using the premixed insulin, human insulin, or premixed human insulin analogs. But here this is a co-formulation which takes into account the advantages of the purely basal insulin like degludec with a purely prandial insulin like aspart, which is available as aspart, and therefore the blood glucose profile that is provided is the the pharmacokinetics of this agent is that it is flat and stable, steady state, and because the insulin monomers slowly and gradually dissociate, whereas the prandial component actually results in the targeting of the postprandial glucose, as we can see here. So the IDEC as part or the co-formulation at steady state has distinct prandial and basal glucose lowering effects, making it a good insulin that would target both the preprandial or the fasting and the postprandial glucose. So, so this was just an introduction to the use of, let's say, the premix, the co-formulation insulin, the advantages of co-formulation, and how could you use it in patients who are already admitted and now who were on a basal bolus regime and now ready for discharge. So, managing hyperglycemia after the discharge. How can we offer effective, safe, and convenient insulin therapy to patients post-discharge from routine ambulatory care? So once daily IDEC aspart versus basal bolus regime results from the step 1 trial, where we can see that there was a similar HbA1c reduction, significantly lower risk of nocturnal hypoglycemia, where we can see this gray color is the glargine with the aspart, whereas the blue color is the IDEC aspart, where we can see that there was lower incidence of nocturnal hypoglycemia compared to glargine. And not only was the HbA1c similar, not only was there decrease in the chances of hypoglycemia, but also the insulin requirement was lesser in this trial, which compared the IDEC aspart with basal bolus regime of a glargine and aspart. And this is results from the step-by-step trial. So the study claims that the 2-in-1 injection is comparable to, let's say, 2 different or 4 different injections. Again, there is real-world evidence on the usage of IDEC aspart in post-discharge COVID-19 type 2 diabetes Indian evidence, which was published presented in the ADA. So this was a single-centered retrospective study from 1st June to 31st December 2020. Type 2 diabetes who were non-compliant to basal bolus after discharge with COVID-19 management, and age more than 18 years. So there were 67 patients, small study, 33 female and 34 males, and the age was around 59 plus minus 10 years. The BMI, they were obese. So after 14 days of discharge, when the patients were discharged on a basal bolus regime, which they were actually receiving in the hospital, it was found that 88% were non-compliant with the basal bolus therapy, because we know that the basal bolus therapy is labor intensive for the patient in the sense that they have to measure their blood glucose, they have to measure their carbohydrate content of the food, and then accordingly decide their pre-meal insulin dosing. And as a result of which 88% of the patients were non-compliant with the basal bolus therapy, and 100% failed to achieve the glycemic goals. Now, these patients non-compliant with the basal bolus were switched to IDEC aspart and EMPA+ minus EMPA+Lina plus 1 gram metformin. And after 13 weeks of therapy, there was a improvement in this hyperglycemia, 100% compliance to therapy, and there was 0 episodes of severe and nocturnal hypoglycemia, and significant reduction in the glycemic parameters with better compliance and improved safety. So however it is, but this was a very small study. Also, they used EMPA+Lina with this combination. So it is with the combination of IDEC aspart. So it is actually very difficult to point out what was responsible for the benefit. But at the same time, I would like to point out that in patients who are already on a basal bolus regime in the hospital, typically discharging them on a basal bolus regime is very difficult for the patients to follow. In that case, in most of the cases, we change our patients to a premix regime, and a premix co-formulation like this could provide a better basal coverage for these patients, and thereby translating into better glycemic control. So this study showed that switching to IDEC aspart plus OADs was an efficacious and safe alternative in post-discharge COVID-19 patients treated with dexamethasone during the hospital inpatient stay. Again, I would like to point out this was a single center study, only 67 patients. They also took oral agents as well as degludec, the combination of aspart with degludec, and therefore difficult to point out which was responsible, but still in patients who are admitted with COVID, or for that matter, for any other reason, needing basal bolus therapy in the hospital, when we discharge them, typically we would do so in most of the cases on a pre-mixed regime or a pre-mixed, let's say, or a co-formulation. So to summarize, glycemic control in the hospital should be a priority, both to enhance the quality and patient stay and to reduce the cost related to the length of stay, and also definitely reduce the mortality also. Uncontrolled diabetes leads to higher ICU admissions, increased morbidity and mortality, and hence it's important to ensure good glycemic control in people with type 2 diabetes. In tune with the Indian realities of diabetes management, once the patient is discharged from the hospital, or even if we, let's say, initiate a patient with insulin in the OPD setting, insulin that addresses both the prandial as well as the fasting are important, and co-formulations are like IDEC aspart are welcome because they offer the total control and can help achieve glycemic goals with safety. In hospitalized patients, always the choice of insulin in most of the cases would be a basal bolus regime. Some patients would be needing even an IV insulin infusion. Post-discharge, IDEC aspart offers the convenience of a single device and providing effective glycemic control and safety as compared to complex basal bolus regime during routine management of diabetes. Thank you so much.
Thank you, Dr. Indira. Thank you so much for your. I would come back after a small video. Thank you. I think Professor Debballo Shannal and Professor Anirban Majumdar are there. If you could unmute and we could have a discussion. We are just 5 minutes, a couple of questions we can take together, 5 to 7 minutes to this scheduled time of conclusion of today's events. Professor Majumdar and Professor Shannal, if you could join us. Indira, the first question, Dr. Indira, for you is, in the hospital scenario for a basal bolus, do you consider that the generation 1 basal insulin or generation 2 basal insulins are more appropriate?
I think so that's an important question. I think both groups of insulin, the generation 1 as well as the generation 2, both are used. Both are appropriate. There is no problem with the use of, I would not say there was not, both are appropriate, I would say. But I think the later generation basal insulins are attractive in the sense that they have less peak, or let's say peak less compared to, let's say, first generation basal insulin, where at least a little peak is there, which can result in nocturnal hypoglycemia. So also they are low. So both are preferred, but yes, I think the extra advantage of the newer generation is that because of being absolutely peakless, the chances of a nocturnal hypoglycemia are less.
India, I think there is some controversy regarding use of this degludec in the hospital practice, that you need to uptitrate the dose at least after 3 days time. And sometimes, in an acute clinical care setting, we actually titrate the dose almost daily. So here is the catch. Now that makes a little difference whether we can use this drug in an acute care setup or not, where actually we need to uptitrate the dose almost daily, which is possible with the conventional glargine. However, I'm a little bit in favor of glargine U300, because in our hospital, if you advise our paramedical staffs to give glargine at say 10 p.m. or 9 p.m., whatever you want to give, say 9 a.m. So it is not always possible for the paramedical staffs to inject the injection exactly on the same time. So if you give IU300 variety, that will give an extra edge that you can actually, you have little some
Plus
amount of
minus 3 hours.
flexibility, plus minus 3 hours. So it will become convenient on part of the paramedical staff. Even if they forget, they can inject it after say 1 hour or so, and still the regime remains perfect.
Dr. Sharnal, your opinion?
Yeah, again, we are gathering experience with regards to glargine U300. Started a few questions on that. We had previous experience with, very small experience, probably inadequate experience with degludec. Though that time, the titration was a little bit difficult, but now the recent evidences also suggest that with degludec also, there is no problem with regards to daily titration.
Yes, it's just
there are
that
papers now coming in.
Yes.
So that is also something which is there. Probably we need to gather more experience with regards to both these molecules, because one advantage probably is that, especially in the hospital setting, nocturnal hypoglycemia is a big issue. And, getting a nocturnal hypoglycemia is very risky, because the patients are more sick, and also from the patient, relatives point of view, that's a problem. Lot of times it's not monitored. So if we have the option of these two second generation of basal insulin in the hospital setting where patients are more critical, more likely to develop nocturnal hypoglycemia, these may have added advantage. Probably we require, and there are papers with both of these molecules with regard to better efficacy and also probably more time in range, the new evolving concept. So probably we require more experience and better follow-up to have more experience. We still have inadequate experience. That is my personal feeling, that our experience we generally still stick with our age-old glargine U100 in most of the settings, but still we require more experience with both these molecules.
With a time range over a short
hospital
period of hospital intensive care extrapolates into better outcomes. Is there any paper on that? Greater time in range in that critical period. Of course, we know that glycemic variability did have adverse cardiac outcomes, etc. But 1:1, looking at time in range to outcomes. I am not aware of papers. Anyone?
No.
No.
But there are some data of use of degludec in the hospital practice.
Yes,
So
this is recently published, where they said that at the 5th day, and discharge time was not delayed, and I think on the day 5, you had a similar in both the arms. So
yeah, the recommendation came from ADA probably year before last, when they first recommended for nasogastric feeding patients who were NPM and use of degludec was favorable. So now they have several recommendations this year that you can use them. Probably we need better experience with degludec, and also there are issues with regards to cost, availability in hospital pharmacy, which are major issues as well.
So I have been using Degludec quite a lot in the hospital settings, and I can say that I think as Dr. Sanyal also pointed out, titration is not necessary that we have to do every 4 days, just at the steady state, concentration takes that much time to come. And also in my personal opinion, personal experience, I found that the insulin requirement for U300 glargine was actually a little higher than what was required for the use of Degludec. So again, that's my experience.
Yeah, that's supported. Perhaps a U300 is required a bit more than U100.
Yes,
that's
so ultimately
there.
that translates to higher cost also. These are expensive molecules. So ultimately they translate to higher
There's another
cost.
question for you, Dr. Indira, before we move into the panel again. The question says that although in the clinical trial, it had been seen that twice daily co-formulation was nearly equal to that of a basal bolus regime with lesser risk of hypoglycemia, but we Indians are very, very high carb consumers. And many of our basal bolus patients do require a bolus injection proportion, which is significantly higher than that of the basal. So in those patients, would you like to try the co-formulation?
So in such group of patients, again, so typically, I think in many of our patients, we start with the formulations once a day. And then which would address that particular meal and the fasting. And if that is not addressed, sometimes we go to co-formulation twice daily, but other options could also be that we use the co-formulation once and give bolus injections, let's say before another major meal. So that would convert to, let's say, two at the most 3 injections, lesser than the 4 injections.
Thank you. And would you really look at, this is my personal question, would you really look at the co-formulation in the in-hospital scenario, particularly?
No, not at all.
Okay.
I hope I didn't convey that message. It would be only in the patients on discharge or in the OPD, but never in the hospital setting, never.
Okay. Thanks to all the speakers today. It was a brilliant day of knowledge exchange, and thanks to everyone who, despite being a Saturday, had joined it. We had clocked plus 3-figure plus at some points of time, which is decent for an online conference. Thanks, Indira, for being there with us. Thank you, Professor Debmallo Shannal and Professor Anirban Majumdar. You have always been spearheading this conference and the actual men behind the scientific show. Thanks for being there.
Thank you so much. Thank you for having me.
And we have to look tomorrow whether evidence-based medicine really has evidence or not. What evolves out of evidence-based medicine? And it was a wonderful talk with a lot of insights from Professor Subhankar Chowdhury, which didn't say that evidence-based medicine is not required, but which pointed out perhaps at precision medicine to individualize the needs and care and not to take the statistical figures. I would refer to one famous quote from Neville Cardus, who was a journalist, a cricket addict. He used to write a lot about cricket. He once said, "The scoreboard is an idiot." To elucidate that, he said, a 200 plus in a flat pitch cannot be compared with the 98 of Gundappa Vishwanath in Chipak against the fiery Andy Roberts. The 98 is much more enjoyable rather than the 200 from Geoffrey Boycott on a flat pitch over 1.5 days. So maybe at times evidences are like that. Thank you so very much. Have a wonderful night, and we meet again after breakfast, or maybe over a virtual breakfast tomorrow morning at 9 a.m., where we would have Professor Dr. Sujoy Ghosh and Professor Ken Ho addressing pan-hypopituitarism. Good night. Shubharatri to everyone.
Thank you. Good night.
Thank you. Good night.